Good morning, everyone. I'm delighted to welcome you to our second conference on student mental health research. Before we get started, I wanted to let you know that you can turn on the live captions in Microsoft Teams through the three dots on the top right corner and click the Turn on Live Captions. If you're having any technical difficulties, please click on the link in the chat for some troubleshooting information. My name is Sherry Bellitz, and I'm the Director of Counseling Services and Campus Wellness at the University of Waterloo. Campus Wellness is committed to enhancing and supporting wellness for all in a safe, respectful, and inclusive environment. We enhance wellness at the individual, community, and systems level through advocacy, building capacity and partnerships, providing dynamic programs and services, and strengthening communities. I'd like to welcome Jim Rush, the Vice President Academic and Provost of the University of Waterloo. Jim is going to kick us off this morning with welcoming remarks. So welcome, and I'll turn it over to you, Jim.
Thanks very much, Sherry, for the introduction, and I'm so pleased to be able to be here today. First of all, I'd like to acknowledge that the University of Waterloo acknowledges that much of our work takes place on the traditional territory of the Attawandaron, Anishinaabe, and Haudenosaunee peoples. Our main campus is situated on the Haldeman Tract, which is the land granted to the Six Nations that includes 6 miles on each side of the Grand River. Our active work towards reconciliation takes place across our campuses through our research, learning, teaching, and community building, including events such as today's event, and is centralized in the Office of Indigenous Relations. I would like to once again thank you for the opportunity to speak virtually with you today. I do look forward to this important day of discussion and dialogue, as I did last year and as I did in anticipation of it, as the recommendations from the PAC SMH and the COSM were refined, and this is one of the expressions of those. The mental health wellness of our students, of course, is a key priority for my office and for the university. And as we near the end of another successful Thrive Month, we also recognize that Thrive is just one of the ways that the University of Waterloo supports student mental health and wellness, along with initiatives like the Wellness Collaborative and our commitment to the Okanagan Charter and so many other individual initiatives that stem from and find their roots in those frameworks. In fact, this second annual Student Mental Health Conference is itself, as I alluded to earlier, a recommendation, it was recommendation 35, I believe, from the President's Advisory Committee on Student Mental Health, which calls for further exploration of the development of a research institute or specialty area in mental health and wellness. This event meets ongoing made by the Committee on Student Mental Health and outlined in the Okanagan Charter, the Wellness Collaborative priorities, and the National Standard for Mental Health and Wellbeing for post-secondary students. However, it's the members of the campus community itself who center well-being in their work and their studies that gives the life to and animates all of these initiatives and everything we're doing. And that is what has brought us all here together today, to listen to one another, be inspired, and to forge new partnerships to improve the supports we offer to students. Like the student experience in general, student mental health is a distributed responsibility with so many individuals, groups, and offices contributing. Last year's conference featured 14 phenomenal presentations, and it is so exciting to see how many students, faculty, and staff are engaged in and committed to student mental health on campus in this way again this year. It's a really good sign, as I've seen other types of conferences and fora develop over the course of my research and professional career, to see that as this conference moves into its second phase, that thematic areas and specializations and groups of sessions are becoming a feature, and that really is I think a very optimistic indicator of the success and the interest in this activity in partial fulfillment of that 35th recommendation from PAC SMH. The last nearly 2 years have really shown us how vitally important it is to focus on mental health of our students, faculty, and staff as we all navigate truly uncharted waters. The disruption that this has caused to our routines, the pivot to online learning and back again to in-person instruction, and the impacts of the working life of the university. And even though we're working on a safe, staged return to campus in the fall term and continuing into the winter term, our circumstances do vividly underscore the importance of research for informing university procedures and policies, and generally speaking, the need for research dealing with student mental health. And again, this forum is one expression of the richness of the lived experience, the expertise, and the ability to implement those into actionable initiatives is so fulfilling as a part of the university community. Throughout the transitions and the disruptions that have come our way, you and your colleagues have continued to make students and their well-being a top priority. I want to thank you for that on behalf of the entire university as part of that distributed network of support. And I'd like to conclude my remarks by really just emphasizing that thank you. Thank you to our researchers and our poster presenters for their enthusiastic participation in today's conference activities, to our students, faculty, and staff who have taken the time to attend today and take part in this important discussion on student mental health. Thank you for staying connected with us and working with us on this important initiative. I hope that the presentations, the ideas that they will inspire, and the discussions that they will generate will continue to help shape our work. Let's commit together to keeping up our momentum and our conversations going today. Thank you very much for being here, and I look forward to an enriching day.
Thanks so much, Jim, for providing us with the broader context of well-being at Waterloo and how our institution has committed to well-being of everyone in our university community. As the Director of Counseling Services, I support our counseling service delivery for students. We work with students along a step care model, so everything from students who are needing online resources through to single session therapy, brief therapy, crisis appointments, and who work with multiple service providers. I'm heartened by the strong commitment to student mental health across campus, from our senior leadership to upstream prevention that examines structural barriers to well-being, such as the social determinants of health. Today's conference is part of Thrive at Waterloo, and there are 3 central goals of Thrive. One of those is to enhance mental health literacy, another is to build healthy habits and self-care skills, and the third is to foster a supportive and inclusive community. As Jim mentioned, Waterloo adopted the Okanagan Charter as a collaborative framework to promote health and well-being of all students, employees, and the broader community and our planet. The Wellness Collaborative at Waterloo is a university-wide initiative to action our commitments to the Okanagan Charter with a focus on mental health and help-seeking behaviors. The Okanagan Charter calls on higher education institutions to generate thriving communities and culture of well-being. Thrive is one way in which our university community comes together to support this call to action. In our commitment to the Charter, we are also called to advance research for health promotion and knowledge in action. Today's conference is a great way to harness the strengths of our own university community to support student mental health. Our hope is that this will spark connections and synergies with our teaching and research. Thank you for joining us today to further advance our collective efforts in this. Before we start our first session, I'd like to remind you of some important logistical items. The same link for the conference will be used for the entire day. When you leave to take a break, you can jump right back in at any time using the same link you used to join this morning. All the presentation for today are being recorded and will be available on the Thrive website later this month. The format of our conference today consists of 10 to 15 minute presentations, followed by a 5-minute question and answer period. Audience members can submit questions through the Q&A function at any time during the presentation. Moderators are monitoring the chat and will ask your questions to the presenters. Let's work together to keep the comments and questions curious, kind, and compassionate. Over the course of today's agenda, some of the topics may feel difficult to discuss, Here are some resources presented on the slide. We will also be putting this information in the chat so you can access them at any time. I'd like to welcome today's first moderator, Melissa Patwarka. Melissa, I'll turn it over to you.
Thank you, Sherry. Our first presenters for today are Stuart McHenry and Natnaiel Dubale. Their presentation is titled The Campus Assessment Tool, a youth-led participatory research project. Stuart Henry is the Knowledge Translation Lead at jack.org, where he works directly with youth to improve mental health systems on campuses across the country. Prior to joining jack.org, Stuart was involved in the academic labor movement and completed his master's degree in migration and ethnic relations from the University of Western Ontario. His master's research and community organizing experience continue to inform the work he does with jack.org today. Natnaiel is a fourth-year undergraduate student studying biology at Trent University. He currently co-leads the jack.org chapter at Trent University's Peterborough campus. Natnaiel got involved with jack.org as he has a strong interest in youth mental health and health promotion in general. In his free time, Natnaiel loves cycling and listening to podcasts. Thank you for sharing your work with us today.
All right, just give me 1 second to get these slides queued up here. Now, can you hear me all right?
Yeah.
And do we see the slides as planned?
Not yet.
Might just be a bit of a lag. One second here. Sorry, folks, just give me 1 second here. Just gonna reshare. This should do it. How about now?
Yeah, perfect.
Sweet. All right, that was the worst part. We got through it.
Okay. So
yeah, feel free to take it away. No, go for it.
Okay, awesome. So hi everyone. Thank you all for being here this morning to hear our presentation, and thank you to the organizers for having us here to discuss the important topic of mental health among students. Our presentation is titled The Campus Assessment Tool, a youth-led participatory research project. So my name is Natnaiel Dubale, my pronouns are he, him, and I'm currently a fourth-year undergraduate student at Trent University, and I had the opportunity to partake in the Campus Assessment Tool project last year.
Morning, everyone, and yeah, thank you for the introduction earlier. I'll just briefly reintroduce myself. So my name is Stuart McHenry, pronouns are he, him. I am the Knowledge Translation Lead here at jack.org, and the Campus Assessment Tool is kind of one of the main projects I oversee, which is awesome because I get to work with fantastic students like Natnaiel on this job, so I definitely love it for that.
So, jack.org is a national charity focused on training and empowering young leaders to take action and change the mental health landscapes at their schools, in their communities, and across the country. Now, one of the ways in which jack.org equips youth to do this work is through the CAT, where jack.org provides young leaders at campuses across the country with both a comprehensive framework and staff support to document, analyze, and make sense of the mental health services, resources, policies, and practices on their campus. Now, this research is conducted almost entirely by students themselves. And this past year, 10 campuses participated. These campuses were Bishop's University, Jakobsen College, Dalhousie University's Agricultural Campus, Lakehead University, Ryerson University, Trent University, the University of Guelph, the University of New Brunswick St. John's Campus, the University of Toronto's St. George Campus, and the University of Windsor.
Thank you for that, Natnaiel. So I'm just briefly going to go over the research methods that we use for this project. So as you can see here in the figure above, student researchers go through 4 separate stages to complete the CAT. So the first section is mostly just an environmental scan of available resources on campus. And most students are able to find all this information on various school web pages. And then the second section goes a little bit deeper into service provision. So this looks at processes in place at the wellness or counseling center. It looks at things such as staffing, wait times, intake processes, frameworks for care, things of that nature. And then students actually gather most of this information through interviews with wellness staff, but actually in Natnaiel's case at Trent, the team was able to secure an interview with the mental health strategist there. So this mental health strategist was able to answer all their questions for sections 2 through 4. So lucky for the team at Trent. And then sections 3 and 4 are more about the upstream policies and practices in place that promote and protect student mental health. So this looks at things like early alert systems, academic accommodations, mental health strategies, trainings, and things of that nature. So as you'll see on the screen there, most of this information is gathered through interviews with staff from student services. And then, sorry, just give me one sec here. So yeah, then the student-led research is accompanied by a survey that is sent out to students at the research campuses. So whereas the student-led research is more or less documenting the services, resources, and policies in place, this survey is trying to understand student perceptions and behaviors towards those services and resources. So we at JAC.org draft the survey in consultation with the student researchers, and then the Student Life Network sends out the survey for us as they tend to have a much larger mailing list at the campuses. This year we got about just over 1,700 responses nationwide, but still most campuses were only polling at about a 1 to 2% rate, which is still quite low. So we're looking into, hopefully improving that sample size and finding new ways to distribute the survey in years to come. So yeah, now we're going to touch on some of the key findings from both the student-led research as well as some of the key insights from the student survey this year. Okay. So yeah, here's a bit of a high-level overview on what we found for the services and resources offered on the 10 campuses. So on the top, resources for various equity-deserving groups are listed. And then for mental health services, those would include counseling or mental health care delivered by a trained professional specifically for those groups, whereas general resources would refer to things like academic or social support groups, clubs, educational resources, and so on. So as you can see, most campuses offer general resources for these equity-deserving groups, but less of them offer mental health services for these communities. And this is definitely important to note because as many of us know, mental health care is often not inclusive of or responsive to the lived experiences of these communities. So definitely some room for improvement there. And then in terms of mental health strategy, 7 out of 10 campuses that participated in the CAT this year have a mental health strategy in place. So this is a document that provides a strategic plan and guidance regarding student mental health on campus and kind of goes over the university's high-level action plan to recognize and respond to the growing concern of student mental health. So over the 3 years the CAT has been conducted, a greater proportion of the studied campuses have adopted these policies, which might indicate increasing attention to and a growing need for strategic alignment on mental health issues on campus. And then in terms of an early alert system, 6 out of 10 campuses have one in place. So these systems enable faculty or staff to connect students to mental health support at early signs of mental health struggle. 3 out of 4 campuses that do not have an early alert system have noted that they're currently working on one or plan on developing one in the near future. And then in terms of post-vention plan, 8 out of 10 campuses that were studied this year do have a suicide response or a post-vention plan. And these plans are essential in preventing suicide clusters and mitigating other negative repercussions of a suicide in the community. And then in terms of wait times, the average wait time for an intake appointment across the 10 campuses was 1.5 weeks and then 2.5 weeks for follow-up. And this would be for non-crisis situations. And these wait time averages were gathered through the interviews with staff from the wellness centers.
Okay, so as you'll see from this figure here, this figure here outlines the factors causing students to struggle. Now, as part of the campus assessment tool, students were asked to list the top 3 stressors they faced during their time as students. And consistent with what youth members of the Jack.org network have reported, university students continue to cite academic stress, financial stress, and the COVID-19 pandemic as the most significant stressors impacting their mental health. Now, this may be stating the obvious, but we wanted to mention the stressors students face before discussing mental health services and students' perceptions of these services. And this figure here highlights which services students used in the past year. So as you can see, one-to-one counseling remains the most utilized and most accessed resource by far. One thing to keep in mind here is that despite there being a wide array of mental health resources other than one-to-one counseling available to students at their campuses, students tend to be most aware of and most comfortable accessing traditional one-to-one counseling. As such, campuses should continue to implement and expand step care to ensure the diversity of resources at their disposal are being used to their full potential, and to ensure students are accessing services best suited to their needs. So for the next 2 slides, we'll be looking at the perception of mental health services among students who have accessed these services in the past year and those who have not. So this figure here indicates that students who have recently accessed mental health services at their campus were likely to rate such services highly. Over 50% of students reported these services were high quality and were responsive to their background and experiences. Furthermore, students also reported that such services were accessible and met their needs. And though this is slightly below half, it still demonstrates a more positive perception of these services relative to students who have not accessed these services. Lastly, this figure demonstrates that among students who have not accessed mental health services within the past year, perceptions were less positive compared to those who had. These results are interesting as they suggest that poor perception of mental health resources offered by universities and colleges may pose a barrier to access and care, as students believe that these services will not be accessible and effective when they need them.
All right, well, thank you for sharing those findings, Natnaiel. So as we wrap up, just wanted to briefly summarize some of our key learnings from this past year's tool. So as we saw, campuses are offering a wide range of options for support, but students are overwhelmingly still using that one-to-one counseling over other options. So like Natnaiel said, with that, improving and promoting alternative options for care, such as peer support, might go a long way in improving access to care and improving the overall quality of care that students receive. And then lastly, if those who don't use services are perceiving them negatively, we definitely need to examine that further, right? Because those perceptions might be a major barrier to help seeking. And as we know, removing those barriers to help seeking is definitely essential in fostering a healthy campus community. So certainly some great insights from the CAT this year, but also points to a need to look much further into some of these early findings. Okay. So yeah, if you are a post-secondary institution like the University of Waterloo, why might you want to complete the CAT? Well, the CAT's definitely going to help you identify key strengths and gaps of your campus mental health systems and help you better focus your health promotion efforts. But really, the biggest value out of the CAT is related to the Committee of Student Mental Health, or COSMH, recommendations 14 and 35, because the CAT really brings the student voice and the student perspective to the forefront of mental health strategy and implementation at your school, right? So the availability, the accessibility, the quality of services and practices isn't going to be fully understood unless we're consulting those who they're intended for, which is the students, right? So the CAT is a great tool to engage students in this process because it empowers them to be directly involved in not only identifying the issues, but building the solutions. And if you are a post-secondary student, why might you want to complete the CAT? Well, as a youth-led participatory research project, the true value and purpose of the CAT is to empower you, the student, with data that allows you to meaningfully participate in the decision-making process. You'll gain a ton of great experience conducting research, interviewing and advocating. This year, we surveyed the students who completed the CAT, and 100% found the project to be valuable for themselves and for their school community. 100% said they gained valuable knowledge and skills from the CAT, and 100% feel empowered to make change on their campus. So definitely some great feedback from the students who participated. So yeah, we'd love to bring the tool to any campus that's interested. All you need is a group of passionate young people that are willing to do the work. And it only takes the students about 15 hours or so to complete the tool. And I believe there's actually a Jack.org chapter, which are student-led clubs. There's one starting up here at Waterloo, I believe, which is super exciting news, and that might be, you know, an awesome avenue to go about completing the CAT. And then overall at U Waterloo, we know that there's a ton of buy-in to improving student mental health with that committee on student mental health, and the CAT's really going to help, you know, with implementing some of those awesome recommendations that came from that committee. And then I know this isn't much of a selling feature, but you'd also get to work with me on the project. So simply just send me an email. It's right there, Stuart@Chacko.org. If you'd like to just chat more, or if you want to get started, yeah, feel free to reach out. And then to see more data from last year's CAT, which was 2019-20, you can visit jack.org/CAT. And then this year's report, which is the one we were going over today, that'll be available on that same link within the next month. So yeah, I think that's it. We're a little short. Definitely, you know, wanted to leave some time for questions if there are any. So yeah, thank you all for listening to our presentation bright and early this morning. We hope you took something meaningful away from it, and have a great time at the conference today.
Thank you so much, Stuart and Natnaiel, for your really thoughtful presentation. I will be moderating the Q&A, so I would encourage anyone joining in to take a moment to put in a question in the chat, and I can read it out for Stuart and Natnaiel. I found that to be a very relevant presentation as someone working within campus wellness at the University of Waterloo. And we are currently embarking on a client satisfaction survey, but what your presentation kind of highlighted for me was this gap in not knowing what non-users' perceptions are of our services, and that is so valuable, to your point, around help-seeking behavior. And I was just curious if you know more around the research of what are some best practices to overcome those perceptions, to kind of build that bridge and get students seeking help earlier on.
Yeah, that's a good question. I don't know, Natnaiel, like you've led the chapter there, Trent. I don't know if you want to speak to any of like the initiatives or some of the things that you do there at Trent to kind of promote things of that nature, and then I can speak to it as well if you'd like.
Sure, yeah. So one of the things I think is really important for you know, changing students' perceptions of the mental health services offered by their campus is having student-led groups. So for example, at Trent we have the Jack.org chapter, we have CAMS Kids chapter, and we have an Active Minds chapter. And so having those chapters, promoting those resources, and having students hearing from other students that that these are effective resources, that these are accessible resources, that if you are in crisis, you can reach out to your university, your university student services office. They're not going to turn you away. I think that goes a really long way in helping to change those perceptions. So that's probably one sort of initiative if you're looking to help improve those perceptions, is to talk to those student chapters, those student groups and student chapters at the University of Waterloo's campus, and see if they might be more willing to promote the resources offered by your university.
Great,
yeah, that's sorry. I'll just quickly chime in with kind of like that. Yeah, that definitely aligns with, I think, what we promote at Jack.org is that peer-to-peer. And I think, as we've been seeing too, like stigma has probably been decreasing over years, but something that's like still a struggle is like knowing what resources are out there and kind of like demystifying what it looks like to actually seek help. So a lot of our Jack chapters like have had a ton of success in just like creating like cheat sheets for how to go about like help seeking and what are the different resources on campus, and trying to like put it into terms that makes sense to young people. So I think that, yeah, that peer-to-peer health promotion is definitely something we we abide by here at jack.org.
Great, thank you. Yeah, I think that the student-led part definitely felt key to kind of the success of this engagement, and is something that really, yeah, excites me about this work as well. In terms of, so often we look to things like our National College Health Assessment data or our Canadian Campus Wellbeing Survey. Those are often kind of population level health measures around student mental health. Has there been any work to kind of align some of this program level data with the population health data? And if so, can you tell us more about that process?
Yeah, I could say this has actually come up a few times recently in some of our conversations with different, institutions and people in the field. And yeah, I would say that it's still something we're kind of looking into, as this only being the third year of the CAP. We're trying to better integrate it with tools like the post-secondary mental health standard and these larger health assessments. I think the survey that comes out of the CAT is not nearly as comprehensive as those, and it's simply meant to be kind of this complementary piece to the student-led research. But I think knowing that more campuses are implementing the Canadian Campus Wellbeing Survey and the National College Health Assessment, trying to make sure that we're not duplicating on work and helping, we all, I think all surveys have kind of similar goals in mind. So I'm trying to figure out better ways to integrate those and work in harmony rather than kind of doing the same work multiple times. So yeah, I think that's kind of the main thing we would add there. And then also part of the CAT, we ask if campuses are collecting and using that data. So that's part of the student research as well, as to try to understand what types of data and what types of health assessments the campus is already using, so that those can be mobilized kind of in their advocacy process. So.
Awesome, thank you. I have a question that just came in from the audience. They're wondering if unaggregated CAT data is openly available or available to academics and researchers.
So what we typically do is we do share the unaggregated data with each of the campuses, so they can have an idea of the behaviors and the perceptions on their campus. In terms of the CAT report, that's something that we only publish as aggregated. But I think if people wanted to look at the data and learn more, you could definitely connect with me and be happy to kind of walk you through it and share different pieces that are interested. But in terms of our national CAT report, we only share the aggregated data, especially because some of the campuses, the sample size is so low that there's not enough really for us to be confidently sharing the data unaggregated. So.
Well, hopefully, thank you for addressing that question, and hopefully today's presentation has sparked some more interest so that those numbers can increase, and the fact that there's also a national comparator, I think, would be a really appealing thing for institutions as well. So maybe to wrap things up, our call to action, if you're interested in learning more to this, is it to get in touch with you, Stuart?
Yeah. So you can visit jack.org/CAT, and then my info's on the website as well. And also, just send me an email directly, just stuart@jack.org, and I'd be happy to to hop on a call and share anything that's of interest to you. So.
Wonderful. Thank you so much for your presentation today. We're going to move on to our next presentation. So it's my pleasure to introduce Margaret Mutumba, who will be speaking about the health and well-being in mothers of African descent, student parents' experiences. Margaret Mutumba is a passionate public health scholar with over 10 years of experience in maternal, child, and sexual and reproductive health in sub-Saharan Africa. Some of her work includes initiatives focused on reduction of maternal mortality, youth impacted or orphaned by the HIV epidemic, sexual and reproductive health advocacy, including addressing barriers to family forming. Margaret is currently completing her PhD in Public Health Sciences, and her research focuses on the accessibility and affordability of fertility care in Sub-Saharan Africa. Margaret is also the founder of a health tech startup, MedAtlas, making it easier to find specialist doctors in Africa. Thank you, Margaret, for sharing your research with us today.
Thank you, Melissa, for that wonderful and warm introduction. Should I share my slides, or do you already have them there? I wasn't sure.
I will see. I know, Shabangi, are you able to share Margaret?
I can certainly share them, yes.
Okay.
Excellent. Okay. I'm hoping you can see that. I'll just put that in presentation mode. All right. Okay. There we go. Good morning, everyone. It's my pleasure to be here. As has been introduced, my name is Margaret Mutumba, and I just want to thank Thrive and the Student Mental Health Research community for putting on this conference today. This is my research on health and well-being of mothers of African descent, and for our presentation today focusing on graduate students that I'm doing along with Professor Elena Niederman. Before I begin, I would like to acknowledge that I live and work on the traditional territory of the Achuandron, Anishinaabe, and Haudenosaunee peoples, and the University of Waterloo is situated on the Haldeman Tract, which is land promised to the Six Nations and includes 10 kilometers on each side of the Grand River. If you are not already engaged, I urge you to engage with the Indigenous Office to find out what the University of Waterloo is doing in terms of truth and reconciliation and how you too can get involved. So in today's presentation, I'm going to briefly introduce myself, and then I'll go over the study overview, what our research aims were, briefly over the methodology and the preliminary research results, as this is still an ongoing study, and what we hope the contributions will be to mental wellness services. So I've already been introduced, and I just won't add to that. I think the only thing that's important to add to that is that I'm originally from Uganda, and my most important job is being a mom, which in part explains my positionality in this research. So now on to our research. So with migration becoming an important part of globalization, Canada has one of the highest immigrant populations, with over 20% of this population being foreign-born. And so according to a study in 2017, Africa is the second largest contributor of immigrants in Canada. However, research shows that women, immigrant women, aged over 25 are more likely to report poor self-perceived health status, including mental health, compared to women born in Canada. Yet the health status of women matters not only to themselves, but is also critical to the health of their families, as they're often the guardians of health for their families. Furthermore, when examining health and well-being in such a large immigrant population, culture plays an important role in the way health is experienced, as health is socially and culturally constructed. Therefore, neglect of cultural context in health is the singular most significant barrier to the progression of the highest standard of health. So therefore, the purpose of this study was to examine the health and experiences of mothers of African descent who had recently moved to Canada within a period of 2 years, to find out how their experiences were, but in this case, the mothers were pursuing graduate education as well. So broadly, our research questions focused on what was their perception of health and well-being, generally speaking, what were their perceived facilitators for positive health as individuals and as mothers, but also what were their perceived barriers to themselves as well as to their families, and how did they respond to those barriers? Why are these questions important, or why is this research important? Because we are hoping that the findings will contribute to fostering culturally responsive health programs and address barriers to access of health for the increasing number of African newcomers to Canada. So briefly, the methodology, this is a qualitative phenomenological study. We used propulsive sampling and snowballing, and then we went about it by semi-structured interviews and had thematic analysis. So for the 15 participants, 6 of them were graduate students at the time of the research. Just briefly over the demographics, their ages were ranging from 30 to 45. Many of them had the range of 1 to 4 children. Countries of origin included Nigeria, Ethiopia, Kenya, and Zambia. And prior to coming to Canada, some of them were self-employed, 2 of them were university lecturers, another was a doctor, and another was in the international development space. So the common themes that came out of our conversations with the mothers, the top 5 included nutrition, social supports, physical exercise, navigating the health system, and 5th was mental health. And for those of us who are a bit curious, the other 10 included time, health policy coverage, finances, sleep and rest, and school pressure. For purposes of this presentation, I'll only go over 4 out of the 5 of the main themes that came up from this study. So the first important theme that came up is nutritional wellness. We all know that the food we eat affects how we feel. And so studies in nutritional psychology have shown that traditional diets such as the Mediterranean or Japanese diet compared to a typical Western diet reduce the risk of depression by 20 to 35%, sorry. And so a Western style diet is linked to a significantly higher risk of depression. So in many African cultures, we celebrate with food. So food has an emotional aspect to it. And so people who are not familiar with the Western diet, this presents significant challenges in terms of not only their physical health, but in terms of their mental wellness. So for our mothers, they talked about access to culturally relevant food stores, with one of the moms saying that when I first came, I didn't know what to buy, I didn't know where to go, and the food was tasting quite different. But over time, I have been able to find the food that I need, which includes bananas, plantain, and maize flour. With another mother saying, and luckily for us Africans, we have African stores where we can always stop by and find African food. Another point that came up is looking at, for instance, Canadian recipes or the Canadian manuscript on recipes and adopting those recipes into traditional cuisine as an important aspect of nutritional wellness. Another thing that came up was going to food markets as opposed to supermarkets to find healthy fruits and vegetables at an affordable cost. Of course, given the fact that there are students, the budget was also an important aspect in terms of nutritional wellness. Last but not least, they talked about eating less takeout, with one of the mothers saying that reduce the frequency of eating outside, because the food they make outside, they use a lot of strange things that you might not want in your own food, like oils and salt. And this was well summarized by one statement from one of the moms, which said, "Food is medicine. If you eat well, you won't fall sick." And that shows the importance of eating well to these mothers. The next thing that was highlighted, an important issue, is social supports. So we all need to feel like we belong and like others care about our well-being. Social support means having a network of family or friends that you can turn to in your time of need. And studies have shown that social support, people who feel like they have a sufficient social support tend to experience lower levels of stress. And poor social support has been linked to depression and loneliness. So by virtue of the fact that my participants were new to Canada, it meant that they had detached from their own social supports from their countries of origin, and therefore were tasked with the goal of creating new supports. And so in terms of social supports, what was mentioned by the participants included finding the right people to be around you, with one of the moms saying that I think having the right circle helps motivate one another. And another mother saying that it's not just any social support, since it's important to find people who are like-minded, who have the same value system, beliefs, and religious backgrounds or commitments. Another thing that came up was the culture shock. With one of the mothers saying that here in particular, I find that majority tend to live individualistic lifestyles. This is not the kind of social interactions we have back home. And that came as a culture shock. I don't know how to interact. I don't know what is socially acceptable. So they struggled with trying to understand how to engage and create those social connections when they moved to Canada. Another thing that came up was having help. Many of them back in their countries of origin had help to support them in the home. With one of the moms saying, back in my country of origin where I lived before, I had more help. So it was easy for me to focus on the things that I had to do. And so now they take up more responsibilities that they otherwise would not have. Last but not least, they talked about struggling in their work environment, saying that I think this social life here is a big challenge. And yes, I had a problem, especially in the context of my work environment. Another thing that came up was access to good health, particularly around healthcare coverage. Many immigrants come here assuming that they will access the best healthcare possible because Canada is a developed country. And yet in reality, everything might be available, but can you afford it or can you afford to wait? So this highlights the importance of informational support in accessing healthcare services, with one of the mothers saying that she had health insurance, at least to cover my medication. Unfortunately, when she went to the pharmacy, she was told that the policy did not cover medication. And she thought it was a mistake because she said, I pay extra to the school to get my drugs covered. And as a student, it's hard to pay that kind of money. And so they were surprised to find out that even with that supplementary payment they were making, medication was not covered. Another issue came around navigating the healthcare system, with one mother saying that I would say the fragmented nature of the healthcare system is challenging in terms of accessing healthcare because you have to go to different places to get different services, or you have to have separate insurance coverage for different services such as dental, vision care, and so on. And so that was a big barrier for them. In terms of mental health, it goes without saying from the presentation before, students experience mental health challenges which significantly impact their ability to finish school. And in this particular case, it also affected their marital relationships. So in this study, the main concerns around mental health came with work relationships and school demands, of course, as well as long distance parenting, which I'll highlight shortly. But one of the statements that came from work relationships was, and I had a problem, especially in my work context, I felt like I was treated differently because of my silence. Yes, some people feel like this person is stupid and so she doesn't know. And so for her, she felt that in her work environment, they were looking down upon her, and that presented challenges on its own. And so now I want to focus on the perception of mental health for this particular group, which was well articulated by this particular mother, where she said, but I think back home, we don't talk much about mental health, but that doesn't mean we don't have those challenges. We have them, but there are systems in place. They're just intertwined in our day-to-day life. You have a friend who you can just, when you feel like, oh my goodness, I want to talk to someone, you can just go there and just cry. This helps you calm down, and that there's somebody who is really concerned about you, but who's really concerned about you and who's there for you. So this is important to highlight, and the most important bit I want to highlight from this statement is somebody who really cares. So the perception around somebody who really cares was very important to the moms. In African culture, these therapeutic conversations are usually had with a friend, someone who the individual knows already cares for them, someone who's really concerned. So this poses a challenge in the Canadian approach to therapy, because in this context, it's the job of the counselor to listen. Whether or not the counselor cares is not a point of reference. And so this creates a disconnect, because someone wants to talk to someone who they believe cares. And in addition to the racism that's intertwined in the healthcare system, it also presents an issue of mistrust. Can a white counselor really care about the things that I go through as maybe a Black immigrant mother, if you yourself have never experienced the kinds of challenges that they are going through? And so this speaks to really understanding that they need someone who they think understands the issue that they're going through, or who has been through the same experience. And studies have shown that Black patients often get better outcomes and better adherence to treatment if they have a provider that either looks like them or can relate to the psychological effects of their experiences. And this impacts the quality or the perception of care that they receive. So in terms of strategies in handling mental wellness, the things that the mothers mentioned the most were prayer, friends and confidants, and faith communities, by saying, for me, my primary management skill here is prayer. That's my first number one that they go to. With another mom saying, I talk to my God and I talk to my friends to help me manage my emotional strength. With also another mother saying that when they feel burdened in terms of their mental well-being, the church they attend is the one that offers them support. Briefly, I'll just go over in terms of parenting what their concerns were for their children. It was mainly the children's ability to make friends, their school performance or adjusting to their new school, the diet of their children, their ability of their children to rest and sleep well. They talked about a good environment and appreciating the parks and the walking spaces in Canada. They also talked about the importance of modeling health to their own children. Of course, the impact of COVID created significant challenges for their children studying from home. But what I want to highlight here is the long distance parenting, because some of the mothers had come to Canada without their children, and so their children were in their country of origin. And so this mother said that I came all by myself. It was a big challenge for me. I think it really impacted me. A lot of other things just because I left my children behind. You combine that with the pressure of school, it has left a mark on my life, really. And I just wanted to highlight that this mom has now been put on long-term anxiety medication that she developed as a result of the depression from leaving her children back home. And so this asks us as an institution to prepare parents who are coming to higher education without their children to understand what kind of barriers mentally they're going to face, and to support them if they have no other choice but to leave their children back home. And so the sources they highlighted mostly for their health support and information were the YMCA, using Google, community sensors, using health services on campus, financial services, public libraries, the food markets. Many of them mentioned faith-based communities, House of Friendship, and of course the Canadian Food Eating Guide, and adapted it to their traditional diets. In terms of contributions to mental wellness, what I hope my presentation has been able to highlight, that culture plays a role in wellness, and so we should integrate culturally informed wellness services. Additionally, social connections are important, especially for people who are new to the region, especially for international students. So how can we create opportunities for student parents and their families to build meaningful connections on campus? Also, mental wellness is strongly linked to spirituality. So how can, as an institution, as a community, how can we partner with faith-based organizations to provide that extension of support? Also, diversify mental wellness therapies to move beyond or adapt CBT. For instance, incorporate nature walks or other ways to reduce mental struggles for this community. Nutritional wellness is strongly linked to mental wellness. So how can we decolonize and diversify the nutritional educational content that we offer? And how can we make it accessible to all students, especially those who are new to the diet or the way of life here? Last but not least, consider long-term informational support. So engage with ethnic or newcomer community organizations as an extension of the services that we provide, that can provide an extra and longer-term support beyond the school setting. These are some references in case you want to read further about my research and what I've highlighted today. Thank you so much for this opportunity to present for you, and keep thriving.
Wow, thank you so much, Margaret, for that thoughtful, yeah, there's so much you just shared that's just sitting with me both intellectually, but also emotionally. Your research spoke to me also as a mother, and I love how you led with that's your most important job. And I think that also came through some of the experiences that you shared with mothers that you worked with. So thank you so much for bringing that to us today. And I'm going to encourage folks who are joining in to send in your questions. I'll keep an eye on that. And in the meantime, Margaret and I are going to chat through some things that stood out to me. I mean, that quote, there were so many beautiful quotes here. Food is medicine. This idea about long distance parenting. And you mentioned at the beginning that neglect, and this also, you brought us back to this as well at the end, that neglect of culture is a huge barrier. So I was starting to think through, as someone who works in campus wellness and works at the University of Waterloo, what's kind of one step that we could take as an institution, as a unit in campus wellness, to begin to foster that culturally responsive care. What would be your recommendation as like a really important for those who are on the line who are practitioners or health promotion or even anyone working in the academic environment. What would be the first step you would want folks to take to increase and foster that culturally responsive care?
Oh, that's a really, really big question. But I think the first thing is, as I guess an individual, as a practitioner, to recognize where your limitations are.
Yeah.
And how much support you can possibly give to an individual who maybe comes from a different culture or has a completely different lived experience. Understand that limitation. And by recognizing that limitation, hopefully that allows you to, one, do your own homework on what those different cultures might be. But I think the most important thing for us, for me, at least from my research that I gathered, we need to partner with community organizations, because as an institution, we don't have enough resources to support the diversity of needs that are available on campus. And yet there are fantastic organizations in the community that have been doing this for a long time and have a deeper understanding of the needs and are probably already providing those services. So how can we network with other organizations that can support these communities longer term, that have different ways of providing mental wellness services, right? Because right now there's a process that the university is already using. It might take a longer time to adapt that. So maybe a shorter term solution would be to engage with other organizations that are providing that culturally relevant support, while we're also doing that internal work as an organization to expand the type of services we offer.
Thank you. That is such a concrete and tangible step that we can take. And it also speaks a little bit to what you heard from the mothers that you were talking about, that, you know, their experience with the mental health system is so intertwined with their day-to-day lives that it is more possibly informal than the systems that here in westernized colonized countries. So that really lines up with what we've said. I mean, I think I could talk to you all day about your research, Margaret. So thank you so much for joining with us today. As questions come in, I might send them to you so you can share back with the group. But I want to thank you so much again for taking your time to share that with us.
Thank you for having me, and have a good rest of the conference, everyone. Feel free to contact me as well.
Great. Thank you, Margaret. Okay, so our last presenters before we take a short stretch break are Renate, Donnovan, and Amanda Cook. Their talk is titled Embedding Wellness Content into First-Year Engineering Curriculum. Renate Donnovan was the first student wellness coordinator in the Faculty of Engineering, beating out the amazing Sam Vinderkokov by only 2 weeks, and is currently on secondment to the Dean's Office in the Faculty of Engineering. She is a PhD candidate in the School of Public Health, researching the relationship between moral injury and mental health in post-secondary environments. She is also a sessional instructor and content contributor for the AHS 105 Mental Health Literacy course. In her spare time, she can be found relaxing with her family or meditative doodling. Amanda Cook is the director of the Sexual Violence Prevention and Response Office at the University of Waterloo. She started on campus 4 years ago as the first sexual violence response coordinator at Waterloo. Since then, the office has grown to include a new full-time response coordinator and 2 contract roles focusing on education and evaluation. Amanda came to this work as a registered social worker, having formerly worked as a therapist in the Sexual Abuse Treatment Program and a child witness specialist with the Child Witness Program, both at Peel Children's Center in Mississauga. Thank you, Renate and Amanda. I'll pass it over to you.
Thank you, Melissa. I very much enjoy teasing Sam about the fact that I beat him by 2 weeks. So I'm just going to share my screen and turn it into an actual slide presentation. There we go. So Amanda and I are just going to cover a little bit of history and context about how all this occurred and the rationale for embedding wellness modules right into first-year engineering courses, how we developed them, and the new module, and then we thought we'd actually just show you the module itself. So this all started with Professor David Wong, who started in his ECE 190 course, noticing, as many of us have, that students sometimes have some challenges transitioning from post-secondary to university. And Professor Wong started embedding life skills right into his first year course. It's an ethics and professional practice course. So these kind of life skills dealing with setbacks, growth mindset, they fit really well with the nature of the content that was already in the course. And then when the wellness coordinator position was created, Professor Wong asked me if I would take over delivering these wellness related modules and include some things on understanding mental health. And then of course the pandemic hit. So we had to figure out how to put these wellness related modules online. And we did that for fall 2020. And then this fall, we just added the new module that Amanda and I will show you in a little bit. So why did we do all of this? Well, as I already mentioned, many of our students were struggling making the transition. And of course, engineering can be a very intense and demanding program. And you'll probably hear several times over the rest of this conference that 75% of mental illness onsets between age 14 and 24, which is, for the most part, our undergraduate students and even some of our graduate students. And so we have an at-risk population, and it can be very tricky to figure out sometimes what is just the challenges shifting to adulting and the post-secondary environment, and what are the fledgling signs of a mental illness kind of starting to onset. And so by helping to increase that help-seeking behavior, by having a little more criteria about maybe this is a good idea to reach out for help, something isn't, it seems like it's more than just workload stress, having more of that information in the hands of the students, we were hoping would help them take action a little sooner before it became a bigger challenge. And then, of course, in the last 5 years, the number of post-secondary students identifying with mental health issues has more than doubled. So we really saw a need for having wellness-related content in the courses, but most importantly, our students asked us to. So engineering students actually have classes from 8:30 to 4:30 Monday to Friday with 1 hour for lunch. And even though Campus Wellness has some amazing workshops and materials available, students just found they could not get there without missing class, which put them very far behind, which then made them more stressed out. And so they said, can you just put it in my courses? And we did. So the in-person, the pre-pandemic, in the before times, as I like to say, we actually worked with the students to develop the wellness modules. So I reached out to the student societies, Engineering Society, ENGSOC, and the ECE Student Society. And in ECE, we also have wellness ambassadors, student wellness ambassadors. So I worked with all of them to develop the modules. I basically asked, what are the biggest challenges you and your peers are having? And then we created workshops around those topics, and then we co-delivered them. So in person, I would do the kind of more theory part, and then the students would do the lived experienced examples, and it worked really wonderfully. Ooh, wrong direction. But then we had to put it all online. So when the pandemic hit, Professor Wong asked me, can we just put these online? And so we did. So we took this same student-informed content, and Professor Wong actually donated 10% of the course grade specifically to the wellness modules. We created assessment. The assessment is actually more formative or reinforcement-based than testing or summative-based. And we also got student feedback on the layout and the design, because at the beginning of the pandemic, you might remember there was a really big push to make everything text-based. And that's because we had problems with firewalls and bandwidth. And so it was very text-based. In order to make it a little more interesting, we've made the modules very interactive, which we'll show you when we get there. But then we, over the summer, we have done some updating. We've reduced some of the text now that more folks are back in Canada in areas with better bandwidth. We've added some videos, and even more fantastic, we added student-created content. So the students created some videos, they've created some content themselves. We'd like to see even more of that in the modules. And then something amazing happened. Folks started to hear about these modules in Professor Wong's courses, and and started asking how they could get them in their courses. So this fall, we're currently piloting these wellness modules in electrical and computer engineering, software engineering, and systems design engineering. And right now we have very preliminary results from last fall with the first 3 modules that we created, more around student response, did they like them, but we don't have any longitudinal data about what kind of impact they made. So hopefully we'll be back at another conference to tell you the impact that they made being present in the courses. And then we're now currently also we are working on increasing the accessibility. One of the things about the interactive pieces that we love so much is they're not fully accessible. So we have created alternative text documents for students who just want a plain PDF and none of the fancy interactive pieces. So that's kind of where we are. And then over the summer, one of the things that happened is we had some challenges in engineering. So engineering has this year a record high of 37% female identifying population. And unfortunately, a lot of the female identifying persons in engineering do experience various types of sexism and gender related violence. So we actually had 2 different departments reach out to Leah Foster, who's actually currently the wellness coordinator in ECE, and ask if we could create a sexual violence related module. So Leah and I talked about it extensively. We felt this was content that needed experts far beyond us, and we reached out to Amanda, Megan, and Stacy in SV Pro, and they helped us develop all the content. So with that, I'm going to hand it over to Amanda.
Thanks, Renate. I'm so excited to be a part of today's conference and to share a little bit about the rationale behind including our content within the engineering module. So for those of you who aren't familiar with the Sexual Violence Prevention and Response Office, we provide support to all of those who've experienced or been impacted by sexual violence. We also lead education on campus to provide sexual violence awareness, including workshops, sharing skills to respond to and prevent sexual violence, collaboration with other departments and units to bring key learning to their spaces, and more. So I'd like to note that the SV Pro operates from the understanding that sexual violence is a public health issue, and as such believe it's most effectively addressed from a community and public health approach. We cannot do this critical work in a silo, so being able to partner with engineering to add content to their wellness module was such an incredible opportunity. So following consultation with Leah and Renate regarding the vision for the module, Stacey Jacobs, the project coordinator for our office, took the lead in developing the content. We believe everyone on campus should have a foundational understanding of key concepts, terms, and practical ways to both respond to a disclosure, as well as prevent sexual violence as an active bystander. This also allows for an opportunity to build upon foundational knowledge through other activities and learnings and so on that happen on campus. We further recognize that this modality of learning is not the best fit for everybody, and that ideally students, staff, and faculty are able to access this kind of learning in a variety of ways. Because sexual violence is a systemic issue, it also intersects with mental health, race, gender identity, gender expression, class, socioeconomic status, homophobia, transphobia, and more. And as you can likely imagine, experiences of sexual violence, responding to a disclosure, witnessing sexual violence all impact the mental health and well-being of individuals. We also recognize the ripple effect that impacts communities on campus, such as in clubs and teams, residence floors, classrooms, labs, and more. We do have a lot of micro communities on campus. So our goal is really to normalize these conversations and exposure to this content and have them occur naturally along all other conversations on campus that connect into the mental health and well-being of our campus community members. So not only is this module such an incredible step forward to bring content into our campus community members, but there's lots of other really incredible ways that we can work with our campus community members. We love collaboration. We love working systemically, and so are always open to hearing the brilliant ideas of our campus community members about the ways in which we can bring content to you. So I will turn it back over to Renate. I think she's ready to go through the module.
I am, thank you. I am. I always find it just a little tricky when you have 2 or 3 things open to find the one you want to share. And I actually want to pull my sorry, I can't click buttons and speak at the same time. I wanted to pull my Learn site over so that you could, so it was in front of me as I'm talking to you. So it's built right in Learn, and when you go in, it looks like any other Learn site, and we have a few pages. We tried to keep it fairly short. It's designed to be the equivalent of approximately an hour and a half of delivery for the students. So there is a welcome page, and we have, this is the format that all 4 of our wellness modules follows. So the welcome page gives you a little bit of a background. It has the instructors, and these are the 2 of the interactive pieces that rotate. Little bit of explanation of what they can expect in the course. These also flip, and a little gamification at the bottom. Excitement, you're now finished 10%, and it's time to go on to the next page. Because several of the modules deal with sensitive content, there is a kind of trigger warning, or before we start, it just gives folks just a little more information of things to think about or keep in mind as they go through the modules. And we also have a backup plan or an opportunity, if, especially with this module in particular, the relationship, consent, and sexual violence module, if folks don't feel that they could complete the module without causing trauma or harm, there's an opportunity to reach out to either Leah or myself, and we'll work with them to come up with alternative options for them so that they don't have to go to the instructor and reveal. But we also don't want anyone to, work through a module and have any kind of negative or adverse response. So this page gives everyone the background of SV Pro. And I was going to get to another page with more interactive. So here's another one with the interactive. It's a way of reducing the amount of text that appears on the page so that it's a little nicer for everyone to look at. It also makes it a little more fun. And the feedback that we've had is the students really do like this interactive component. They also tell me that it looks like no Learn site they've ever seen before, which is kind of wonderful. This is also a click and reveal that is a really great way to work with content like the myths. And I could click the buttons all day, but I won't. And what's the next page? We really felt consent was really important to understand what it was. So we have a page on consent. We've tried to put in some videos, break it up so it looks more interesting for them. And how to respond to disclosure, lists with some graphics to make it a little more visual appealing. And again, as I mentioned, some of these really fun pieces are not fully accessible, so we created the alternative, just straight PDF for them. And I just don't want to go outside of the module. I think we've gotten, oh, here's some more click and reveal. This is a similar one. So one of the things we did was we used several interactive elements, but not too many, because we didn't want it to kind of be, you can make too much and it can be overdone. So we wanted a little bit there and to spread it up with a variety of different types of approaches, links that they can click through to. And then we do have, I'm going back up to the top, we do have a section of additional resources. So there's quite often individuals who want more information or more detail, individuals who need more support, and it's too big to go into a 1.5 hour delivery. So there's, in all of the wellness wellness modules, there's an additional resources section that has a number of resources that they can access and just finding more information or supports that they need on campus. So that's our, I'm not sure how we did for time. That's our module. Do you have any questions for us? I don't know if I should leave it up in case anyone wants to go back to any particular pages. We'll show Amanda and Megan's awesome pictures.
Thanks, that was great to see an interactive tour as well. So thank you, Renate and Amanda, for this really important work that you're leading. I'll start off the Q&A with a question that's come from some of our attendees today. The first one is, how do you evaluate wellness of students both on their academic and co-op terms? And are there any key differences for the female identifying population?
I wouldn't say at this point we have evaluated wellness in that respect. We work with the Student Association. NSOC does a wellness survey of the students every term, and ECE Society also does a wellness survey with the students. So we have worked with the student groups on creating the survey questions, and those go out to people on co-op as well. Yeah, I'm not sure if that was how you're assessing in this module, or how are we assessing the level of wellness overall, but certainly that is an ongoing question in terms of the overall level of wellness that we're working on. But right now, predominantly, that's the way we do it in combination with the student societies. Did I answer the question?
Yeah, I mean, I think, and the only other element of it, but you may have answered that already, Renate, is in the work you have done, have you come across any key differences for the female identifying population?
In the last NSOC survey that went out, they did have a demographics section. I don't specifically remember if they broke it out by levels of wellness by gender. That's a good question. So I'm actually going to go back and check that. We know that we certainly have a lot more students just reporting, female identifying students reporting situations of sexism or inappropriate conduct, both on co-op and in the classroom environments. I don't know how much it's actually been recorded. That's another good question. I'll find that one out too.
That's great. When you come back to present about the impact next year, you can also share these findings.
I will.
These are great questions, and also great to know that that you're doing some work to collect some of this wellness data within engineering. That's fantastic. Another question that came in was if you're able to share the link to the interactive website. Now I see that that's on Learn. Is that something that is shareable?
It is my Learn sandbox. And so what I would say is if folks email me, I will, so in order to find the chat, I have to stop sharing. I will put my email address in the chat. If any of you are interested in developing wellness modules, because we have one on time management, one on understanding mental health, very, very basic, and one on resilience or strategy building. We are huge share bearers in engineering, and we are very happy to share any of our content or the modules directly. So just email me and I will give you, I can't talk and speak and type at the same time. If you email me, I'll give you access to my sandbox and you can go in and take a look. The other thing that Sam and Leah have really been working on over the past year with the pandemic, like everyone, we had to scramble to support students virtually. We've created we had started creating it when I was still in the role, but Leah and Sam really expanded it over the past year, a self-directed wellness site in Learn for Eng Wellness. And the students actually created quite a few modules that are in that. They're different from this. They're obviously not for any kind of grade, but it was really wonderful to have more and more student-led content in that site. And so it's not attached to any course in particular, but you actually can go into the Learn site and just I think it's in Human Resources. No, it's in Learn. You can go into Learn and self-register right into it. It's Eng Wellness Learn site. So I can't remember what the actual name is, but there's incredible student content in there if you want to check that one out.
That's great, thank you. And thanks for, some folks are saying that they can't see your email address, so we'll make sure we have a way to get this. I think, and don't worry, Megan is going to help with getting that email address out so folks know how to reach.
It's basically my name that you can see on the slide. So you can just do r.donnovan, or you can do renate.donnovan@uwaterloo.ca. So the usual kind of
Thank you. The other thing that came through the chat, and maybe this is someone you've already connected with, Renate and Amanda, is that I'm now trying to find it. David Wang. So David Wang
Wong.
is Wong. Sorry.
He puts a question on one of his quizzes to see if you pronounced the name correctly.
Hi, David. Okay, so David Wong, this is like the initial professor who did this. And so David is saying here that they're not finding any differences in the female students participating. So going back to that original question that David says the female students do not report feeling marginalized. So great, David. Again, look forward to hearing from you next year as well. And so that was certainly something that stood out to me, was the student-led approach that you've taken, that I think is so important. And so when you first embarked on this, how was it students who kind of helped dictate what, because there's so much wellness content that can go into a course, was it students that led kind of, this is the information we feel we need, or was it directed by, how did you prioritize that? Oh, they do.
So some of what led it is exactly what everyone else on the campus, I think, is experiencing, which is we have amazing resources and students aren't using them. And so we just wanted to ask the question, why? Like, what's happening? Do we have the wrong resources? Did we miss the mark in how we created them? Is it accessibility issues? Like their courses are scheduled from 8:30 to 4:30 and they cannot get across campus to use them? What's going on? And so, you know, a lot of it is that they do really appreciate that peer element and aspect. And we just really wanted to make sure that whatever we created, it was going to be used. And so it really started with some of those kinds of questions, which is, how do we get students to use them? What would make them more appealing to students so that would be more uptake? Because they're certainly telling us they need support. So if they need support, but they're not using the support that's there, what's happening? What's the disconnect? And so that was kind of what started the conversations, and then it led into, if we just needed to start with 3, which is where we started, what would be the 3 most important topics? And so time management was certainly considered one of them. Understanding kind of what mental health is and normalizing the mental health conversation, and that everyone experiences ups and downs in their life. And then also some tools and strategies that would take them through their entire program and help them manage their well-being. Those were kind of the top 3. I think the next one also that the students are requesting is staying motivated through your entire university program. So motivation, the students have actually created some student-led workshops on motivation. So there's more topics actually that we would like to create. We just haven't had a chance to get there yet. And we are hoping to look at how we can embed all of the different topics, not just in first year, but potentially throughout the engineering program so that they can be reinforced. So certain concepts get introduced in first year and then we reinforce them second, third year, and just help keep building those skills across the degrees. That's the kind of long-term vision. But that was kind of how it started. We wanted to make sure we were building the right things that would have uptake. And, you know, when you co-deliver with the student, there's more credibility when the student gives the example of how they applied that strategy and it actually worked for them. So we really wanted that lived experience. And we also really believe in nothing about me without me. And so since it's about them, they needed to, well, it's about all of us really, because we all have mental health and we all need strategies and support at different times. But we really wanted to make sure they were part of that whole process. So I think that was a long answer, but I think covered everything you asked.
But I think a very important part, right? And something that kind of is themed across our presentations this morning. So thank you for speaking to that. I do have an important correction to make. Thankfully, David caught that I read out his response wrong. So females do feel marginalized based on the survey data. So apologies to David, for misrepresenting your comment there. They do feel marginalized. So this is certainly something that I imagine informed and was some of the impetus for the approach you've taken. So thank you.
Absolutely, and I don't know how widespread the challenges are in other STEM programs in math and science, and I've certainly had many female students tell me that they felt targeted, that there were populations within their cohort that were trying to get rid of the female students. So that's just a really disheartening thing to hear in today's day and age, and just adds to the stress. I mean, the program is challenging enough without also feeling things like you don't belong here. So I think it was really important, and inequity and diversity inclusion would be another really valuable module we'd like to work on. But this was a good start with Amanda and team, because it's really important, and they do experience quite a bit of sexism as well.
Well, thank you. Unfortunately, we have run out of time. Certainly, this is something that I think there's that opportunity to scale up to other departments and faculties across campus. So thank you for leading this work and sharing it with us today.
Thanks for having us.
Yeah.
Thank you.
Thanks. So what a great start to our conference today. I know I'm already leaving with lots of really exciting takeaways and some action items to follow up on. We are going to take a 10-minute break now, so please take some time to get water and move around. And a reminder that you can just use that same link, and you can join us again at 10:35 for the next presentations. Thanks, everyone.
Hello, everybody. Welcome back from the break, or welcome to the conference if you're just joining us right now. My name is Andrea Santi, and I'm a member of the Wellness Collaborative Advisory Committee, and I'll be moderating the next 2 sessions for us this morning. Up next, we have a presentation called Developing Community Amidst COVID-19, and this is being presented by Caleb Chacko. Caleb is the 3rd-year computer engineering student at the University of Waterloo, who is dedicated to creating a positive community within electrical and computer engineering. As an Eng Wellness Ambassador, he utilizes his strong interpersonal skills along with his genuine concern for those around him to design new initiatives promoting health and well-being within his class. He has a passion for leveraging virtual environments to create connections, a sense of community, and to promote wellness. Please join me in welcoming Caleb. I'll pass it over to you.
Thank you, Andrea. Yes, thank you. One other thing I forgot to mention within that intro is I'm also part of the Electrical and Computer Engineering Student Society, also known as ECE. And that's another thing that we're looking to strive for is community, even amidst being virtual. So with COVID, we've all faced new challenges, and one of the big ones currently is figuring out how to keep that sense of community, even though we're all virtual. Today, I want to discuss a unique idea myself, as well as the wellness team, has come up with to try and increase the sense of belonging. So first, I'm just going to quickly go over an overview of how this presentation will go. We're going to discuss the context, so pandemic and how it's faced, some of the sense of belonging, what wellness reps do, and some of the approaches we took to try and increase that community. Afterwards, we're going to talk about a specific approach called Gather Town. We're going to talk about what it is and the benefits to it. We'll then discuss some of the features that we implemented to boost wellness, social aspects. We'll then talk about some of the results that we saw, so student feedback and some of the next steps. And at the very end, I'm going to give you a live demo. You'll get to try it out yourself, and we'll have a Q&A. So as all of you are aware, we had a global pandemic last year, and that brought a lot of new challenges, finding new dynamics with friends, family, virtually, and also trying to figure out how to study online for students. This was definitely a huge area of anxiety, and actually across the board, young adults face some of the most increase in anxiety through this. And this is something that we saw through our department as well. So that led to a problem. We had all these students that were physically isolated now from their classmates, and it provided a lack of belonging within the class. So as wellness reps, our job through this time was to find new ways to be able to provide that sense of community that was missing. So we tried a bunch of different approaches from the very beginning of the pandemic. We had study sessions. So if you've ever heard of Bongo, it's like Zoom or WebEx. And we had people that would join and they'd study together. We had virtual game nights every week. So Jackbox, Scribble.io, a way that people could get a chance to meet new people. And we also had great resources provided by Eng Wellness. There was infographics, videos, pictures, and all these resources were across the internet in different places. These approaches worked pretty well for the most part, but we had some mixed results. Some of the resources that we had wouldn't get as many views as we'd hoped, considering how big of a class that we are. Some of the game nights and stuff, we have some high attendance sometimes, some low attendance. So it was mixed. Last term, one of the goals that we were really aiming for was to be able to make a bit more of a steady result. We wanted to see students see some of these resources more frequently. The next approach that we're going to talk about is GatherTown. So as I was talking about, that goal last term was to find a way to have these resources used by students. And a few days after that meeting, I actually talked to another wellness rep, and she talked to me about GatherTown. Now at the time, we were thinking of GatherTown as more of a social platform, a way that people could meet other people in a bit more of a natural way. But we thought this actually might be a good way to integrate a bunch of different things, including adding wellness resources to the platform. So let me quickly talk to you about what GatherTown is. It's a virtual platform that utilizes proximity chat. So as you walk closer to someone, their camera comes into view, but then if you walk away, it starts to distance. It definitely allows you to simulate more of like talking to people in real life, and it gives a bit more of a natural feeling. So we thought this would be a great approach, but before we decided to take it on completely, we thought we'd do a quick demo with some classmates, myself and some wellness reps. We got together 20 students, and we encouraged them just to take a look around, look at some of the different features, and just talk to people, see what it's like to be inside GatherTown. From that, we collected feedback, and one of the main things that came up was just the fact that it felt almost like you're in person at times. You would go up to someone and talk with them, but then on the side, you could hear these different side conversations. It almost felt like going out of a lecture hall and just starting to talk with people. That was really exciting to see. It was something very unique that Zoom and WebEx didn't really have to offer. So let me just recap quickly. So the previous approach that we took, we had wellness resources, but they were scattered online, so we have some views here and there. A lot of the activities that we tried using were on various platforms. And there wasn't really a way of having large groups of people connect with each other or one-on-one. So with GatherTown, we had a platform that was available to users 24/7. We wanted this to be like a plaza. So if people wanted to come here at any time, they could just enter. There'd be resources there for them. They could have activities. It was all there in one place. And of course, you can meet with multiple people as if it was real life without being in real life. So some of the GatherTown features that we added, there was 3 different things that we wanted to do to supplement the online learning. We had social space, we had study spaces, and we had wellness resources. So the first one was social space. We wanted this to be a place where people could meet together after an intense day of studying. So we had a rooftop cafe, different meeting areas, and a game room. So there was opportunities for people to interact without having to just hold a conversation. They could play some games, some cards, board games, video games, or just chat. We also had study spaces, so if people wanted to talk about labs, assignments together, we had spots that they could do that. We also had a shared whiteboard where if they wanted to collaborate on something, they could all go to this one spot and they could start drawing out different equations, different ideas that they had about projects, or maybe how to study for a midterm. We also have, of course, wellness resources. This is the main thing that we wanted to incorporate with this platform. And so we have a variety of resources here. There's the wellness videos. So we had a playlist on YouTube of study tips, mental health tips. And so we embedded that into our TV, our virtual TV. We also had emergency contacts. So if people ever needed to reach out for help, mental health, depression, whatever it might be, we had resources that they could access immediately. We decided to also scatter some of those infographics I talked about. We put them across the rooms so that as you're walking, you could actually walk up to a poster and view it. Some of them have like mental health or study tips, different ways that you can cope with depression, examples like that. We also had a gratitude board. So on Bell Let's Talk Day, we had a board in E7 where you could put down things that you're grateful for. We thought it would be cool to have something more permanent inside a virtual space. So with this, we received a lot of great feedback from students. We launched this platform as like a beta or a pilot back in July. And during the launch day, we had about 30 to 40 people that came in. They explored different wellness ideas, resources. We also had weekly social events that had about 10 to 20 people attend. This would be like games night, like Among Us, or we would have pets from our class come in. We had the professor join a few times. And then we also had about 3 to 6 students that would join just to discuss courses, studying together. Now, again, these numbers are more from the pilot. The pilot was just our class, about 100 200 people. And while it might not seem like much, this is a large engagement number, especially for our department. We're hoping to see that increase as we continue. I also want to discuss a few quotes that we had from some of the feedback, as I think that kind of shows some of the benefits to this platform. One person mentioned that venting is therapeutic and they didn't feel alone in the 3A struggle anymore. 3A is a term, if you're unaware, and it was really uplifting hearing that. That term was really tough for a lot of people in our class, and a lot of us share the same emotions. Being able to talk about it definitely eased some of the people's burdens. Someone also mentioned enjoy meeting people I haven't talked to in a long time. I think a lot of us felt that. So some of these events, you'd see people you hadn't seen in over a year and a half. It was good just to catch up and see what life was like for them. And another person mentioned, I love the whole idea, everything. We had a lot of people mention that, just the idea of it coming up. It was exciting for them. And so from this, we had the option to go to the undergrad advising team to ask for approval, and we did that. They approved it, and then we took it to the ECE department to ask for financial backing, and they also approved it. So from that is the next steps, and this is kind of what we're in right now this term. We're looking to design a new GatherTown space that has a bit bigger of an area for more people. We're thinking of having more meeting rooms. So like if we have something more official, like wellness events, which I'll talk about briefly, as well as spots for more games and activities. So I mentioned wellness events. We had a time management workshop actually that happened last week. We had someone from the Student Success Office come in and they talked about time management, some of the tips. And because of GatherTown, we were actually able to have it where this person would go table to table and ask questions that students might have, and they actually got to interact together on a shared whiteboard to be able to help them flesh out what a schedule might look like. We also had we're planning to have a UW counseling panel, and that's coming up in I think 2 or 3 weeks. We're gonna have someone from the counseling services come in, talk about what they do and how to reach out to them, as well as provide answers for any questions students might have. So we're hoping some of these will help bridge the gap between students and the resources that are already in place at the University of Waterloo. And finally, because I'm part of the ECE Society, we're also looking to run some social events. So we ran one back in September called the Welcome Back Party. We had people come in, just hang out. We also had a few other events throughout the term, and we're looking to do that in the future as well. So with that, I'd like to tour the space. I will share my screen. I think I sent this to Grace. I don't know who has it, but there's also an announcement that should be posted with a link to this Gathertown space. You're welcome to try it out. One thing I do encourage you though is that look at the bottom left. If it says 25 users or more, I encourage you to wait just until after this presentation to look at it. The max right now is 25 people because the space is only free. So don't worry if you can't right now. If you see it's 25, just wait until maybe a few hours later, and then feel free to click on it. It should be available for the next day or two.
Awesome, that's great. So Caleb, are you just looking for, oh yeah, I see your screen.
Yeah,
there it is, perfect.
Changing the tab. Okay, so welcome to Gathertown. This is the Wellness Hub, as we call it. I'm just gonna quickly go over a few features, and then Andrea, if you want, we can go through a few Q&A as I'm going through here. Would that be okay?
Sure.
Okay, so here's some of the wellness resources we talked about. You can pull up videos from the playlist. This one's on stigma. We have different emergency contacts. If at any point people want to just look for the counseling services, if there's emergency or something, they can go here. Mention that there's the gratitude board. In Gathertown, one of the cool things is you can embed pretty much anything online. And so you can just attach a link and it'll open up in this box. You can have people, if there are people here, you can see them up here with the camera, and you can interact with the board. Mentioned posters. We have infographics here. So you can see there's a preview of it, but then if you click X, you can go into it and look a bit more at this infographic, see some of the causes, some symptoms, tips. The other great thing is in Zoom, and even here you can have like a presenter. You can also do that in Gathertown. So if you want to present to everyone in the room, there's these spaces that you can use that you can just communicate to the whole room. We also have private areas. These are kind of like Zoom breakout rooms, where if you go into a certain space, you can talk to just those people in that bubble. We've also included some games. So we've got a shared piano, so you can actually play piano together. We've got games like Catan, poker, code names, different things just to be able to interact in a different way rather than just chatting. You can see we have different study rooms here that people can just use to chat or discuss about things. And then up here, we have a rooftop. So we use this a lot for social events. Our last one was Among Us. So another cool thing with Gathertown is you can embed pretty much any type of picture that you'd like and have custom ones. See, we have Among Us guys. And then here's the shared study board. This is kind of one of the last things I want to show. We use this for our, I think it was analog signals course. We had a midterm coming up. And so a lot of us just came in here. We started working through problems. If we had questions, we would go through these together. We went through some trigonometry basics. So yeah, you can just see it, how much this was used over the course of a few days.
That's really neat.
Yes.
It reminds me of, walking through campus and in the Quantum Nano Center and seeing just collaboration on the whiteboard there.
Yeah,
it looks just like that. This is a really cool tool. I had actually heard of it once before and used it once, and I really like what you've done with this to customize it for students in your department, and creating all these different areas like the rooftop space and the different rooms, shared piano, gratitude board. It's really really awesome. We did have one question come in, so I'll move to that to ask you, and feel free if others have questions to put them into the Q&A, and I can publish those as we go along here. So the first question is from Christine Zaza, and her question is, was accessibility testing part of the pilot, i.e. to identify and address access issues for students with disabilities?
In terms of disabilities, like not being able to speak or not being able to view the platform, what type of accessibilities would you be?
She didn't specify in the question. Okay. I'm thinking, and feel free to correct me, Christine, if you have additional thoughts on this, but I'm thinking if there are kind of visual kind of accessibilities with colors or you know, text and things like that. I know, like, obviously having a high level of contrast is sort of a best practice, I think, in most cases. Things like that. Yeah, so it could be around visual, even audio things. I know you mentioned the proximity chat. I'm not sure if there's anything from an accessibility standpoint there that that came up or that was tested at all.
Yeah, for the beta test, there aren't a lot of visual things that we did after the accessibility. With the new platform that we are creating, there's a bit more. One thing, for instance, is I color-coded these chairs to make it easier for a presenter to talk about which group. In our new space, we actually have it so that there's numbers on each table, so you don't have to have color to be able to see it. Another thing is arrows, ways to show where to go. A lot of people got lost with this one. This door is a bit confusing to some people.
Right.
So in terms of visual, that's some of the things that we're looking to implement with the new space. With more the audio, it's a bit hard with the proximity chat to be able to use like closed captioning. You might be able to use that with Google Chrome. If someone talks, it has like an automated closed captioning. One of the things we did find, if people weren't able to use a mic, we did use the chat fairly often. So if we had important things to discuss, just like Zoom, you can talk to people specifically. So some people weren't as comfortable sharing audio, so we would actually just message them in here.
Awesome. So you spoke a little about navigation and with the arrows. I know that's one thing Christine messaged me about. Did anything come up in terms of the use of a screen reader with any folks using GatherTown?
That hasn't come up yet, but that is something that is definitely good to consider, especially for larger events.
And are you able to use either exclusively a mouse or exclusively a keyboard in GatherTown?
You can use, I'm not actually sure about the mouse. That's a great question. You can use the keyboard exclusively. You don't need to use the mouse. In terms of just the mouse, I'm not entirely sure. There's also a mobile version, and in the mobile version, you can actually just tap where you want to go rather than using arrows. So that gives you a bit more fun.
Yeah, that's good to know. I know the one time that I used GatherTown, there were a bunch of us in there. This was for my part-time grad school, and I got stuck behind people. We were trying to navigate going through, and then our professor told us about like the ghost feature where you could, I forget the button you hold down, you could literally walk through like a whole line of people to get around. So little tips like that were helpful too for me. But yeah, I think it's a really great way to connect with students. I always love hearing from students too, so this is really fantastic, and we appreciate you being here today.
Yes, thank you, Andrea.
Yeah, you're welcome, Caleb. It is getting time to move on to our next presenter, so if there are any other questions that come in, we can definitely send them your way. But thank you so much again, and hope you can stay for more of the conference today.
Yes, thank you. Take care, guys.
Thanks, Caleb. All right, so now we're going to move on to our next presentation. This one is called Searching for Support, My Journey Through the Mental Health System, and this will be presented by Christine Jakobsen. So Christine graduated from the University of Waterloo in Health Studies in 2016. She has been working here at Waterloo in the Registrar's Office for the past 3 years. She spends much of her time at the arena playing and coaching Renate. She also has a 5-year-old daughter and is a member of the LGBT community. Please give a warm welcome to Christine, and Christine, I'll pass it over to you now.
Thanks, Andrea. So like you heard, my name is Christine, and my presentation is going to be a little different. I'm going to be talking about my journey through the mental health system so you can see the navigation of that from the inside. So honestly, I probably shouldn't be here talking to you. 4 months ago, I would not have been here talking to you. 4 months ago, I was hiding in a hospital room trying to avoid staff because there was only a few people that I would talk to. 6 months ago, I was still here working, but I was having a really hard time being able to collaborate with anybody. I didn't want to do team activities. I didn't want to participate in team meetings because it scared me so much. If I had to, I would usually send my information to my manager and hope that she would send it. So I'm going to talk a little bit about how I got to that point and how I am where I am today. So very, very quick, brief background about myself. I'm an only child. I grew up in a very authoritative household. My dad's word was law, and I was raised with fear. It's a great way to raise obedient children. It's not such a great way to raise functionally and mentally stable adults. I started self-harming when I was 17. I was sexually assaulted when I was 18, but I didn't do much about it at that time. I went on to university, I graduated, I got pregnant after university, I got married, and for a couple of years I stopped self-harming and lived a relatively normal life, as much as normal is. After 2 years though, I realized that this relationship is not the one that I should be in. I'm not straight, I'm gay, and I had to come to terms with that, tell my husband, and we separated, on very good terms though. That brings us up to summer 2019, and that's where my mental health journey really starts in earnest. So after this happened, I felt myself going down again. I knew that this probably wasn't going to turn out well, and I should be proactive and try and get some help. So we have the EAP program here at Waterloo for staff. I decided to call that. I talked to an intake counselor, gave her a very brief, awkward history over the phone, and I got assigned a counselor. So I go to see this community counselor, and one of the first things I ask is, how much do appointments cost? Because I know that the EAP program only covers a certain number of appointments, and I'm pretty sure I'm going to need more than that. Her response was, you're not going to need more than that. I can fix anybody in 3 to 4 appointments. You come in, you tell me your problem, that's it, I'll fix it. Okay, seems kind of weird to me, but what do I know? It's not my specialty. So I go in, I try to talk to her, but of course, having super high anxiety and fear, I cannot just spill my life story to her in one appointment. It's not happening. After a couple appointments, she says, well, you seem well adjusted. You're participating at work, you're doing everything, your daughter's fine. I don't think you need to be here. Is there anything else that you're not telling me? I say, well, yes, there is. And I'm told, well, if you're not ready to talk, then I can't help you. Maybe you should try massage therapy and come back to me later. Obviously, I didn't come back to her later. I left that appointment feeling very confused. Okay, professionals say I'm fine. I guess I'm fine. And I already do massage therapy, so I'm not sure what that's going to help. A month later, I'm still feeling down. I'm starting to self-harm again. And I think, okay, what can I do now? So I go to my family doctor. He tells me my options are community counseling, which I already tried, didn't go so well, or I can go to the ER because psychiatrists are not taking new patients in our area. I'm feeling productive that day, so I decide to try the ER. Go in with a friend, wait most of the day, finally get to talk to a psych intake counselor. Very abrupt, very brief. Are you suicidal right at this moment? Do you have a plan right now? No, then we can't help you. Not right now. You don't need to be here. The only good thing I get out of that is that I get a psychiatrist appointment, which is wonderful because it's the only way to get one. That appointment is a month away, so I spend the next month just waiting. I do not much. I keep working, I live my life as best as I can, and I go back and forth. I take a friend with me to this appointment, not a close friend, but someone I really trust. We go into this appointment, we get 20 minutes into the 60-minute assessment, and the psychiatrist says, I don't think you can fix this in an appointment. I think you need to be in the hospital. Have you considered being inpatient? And I said, oh yes, of course I have, but I went there and they said I was fine. He looks at me and says, I don't think you're fine. I think you really need to be in there. So I agree. We go across the street conveniently where the hospital was, and this time I get held. So I'm involuntarily held or formed for 3 days. I get admitted into the ER. It is so busy with other psych patients as well who have been formed that there are 2 or 3 of us to each of those little ER bays. We wait there for a couple of days, not really doing anything. Eventually I get moved to ASU, which is the Assessment and Stabilization Unit. It's a very terrifying place if you are coming in new, if you're coming in like I am. It's great if you need to be. It's great if you are in the middle of a psychotic break, if you're coming down off of drugs, if you are suicidal at that active moment. It's not so great if you are afraid of everything, high anxiety, and just thinking about suicide. It's a very small area, 6 rooms, concrete walls, glass fronts and glass sides, and that is about it. Sorry, I was just taking a look at the comments there. You don't have your clothes, they take your clothes, they give you hospital, not gowns, but paper clothes that are in the color of psych, so if you happen to get out of there, everyone knows you're a psych patient. And that's about it. The only thing you can do is read books or write with a crayon because you're not allowed to have a pen or a pencil. So I stay in there for a few days. I finally get moved to the actual psych unit when there's room. It's a little better. I get my clothes back, which is very exciting. There's still not much to do, but at least it's a bigger space so I can walk around, and there is one TV for everyone. So I spend a lot of time watching old Western movies and hockey. When I'm ready to leave there, I get a general diagnosis of depression and generalized anxiety. I don't feel like that quite fits me, but okay, that's what they're giving me. They give me medication, they send me out, I'm no longer a danger to myself, and back I go into Christmas. It's the end of 2019, Christmas happens, it's fine, I'm separated at this point, so I have my daughter half the time and half the time I don't. I've been to the hospital, I feel like I've used the resources and I should feel better, but I really don't. My daughter's with her dad half the time. When I don't have her, I'm self-harming more. It's more than before I went to the hospital. I really don't care at this point. Unsurprisingly, I end up back in the hospital after a couple weeks into January. I'm very fortunate to have amazing coworkers who care, and I actually ended up in the hospital from Waterloo, from being at work. I go back this time, we go through another intake. This time I get admitted voluntarily, and I go through the same process. I wait in ER for a couple days. I go into ASU again, which yes, resulted in a little fight between me and security because I did not want to go back to that place. This time when I'm in ASU, the ER department is so full of psych patients that they have to push us through even though the psych department is full. So I get surged, as it's called, into a ward in the psych department. It's meant for 4 people. I was surged as number 5. So I was in a bed in the middle of the room without a wall, and I was brought in the dark at, I don't know, 11 o'clock at night while everyone else was sleeping. It's very hard to navigate yourself in a room in the dark that you've never been in before. They also super surged that room up to 6. I can't even imagine what it would be like with 6 people. This time when I'm in there, I get a diagnosis of borderline personality disorder, which fits me a lot better. I read stuff written about it. The doctor gives me stuff. It makes far more sense. So I'm okay with that diagnosis. Because I have one now, I can be put on the wait list for group therapies. So I am put on the wait list for CBT, which is cognitive behavioral therapy. Its wait time is around 1 year. I'm also put on the wait list for Skills for Safer Living, which is for people who have attempted or strongly contemplated suicide. The wait list for that is 1 to 2 years. So up to 2 years if you have attempted suicide to get into a group that is to help you prevent that, which just blows my mind. I get released out of the hospital again. This time I do manage to find an amazing social worker that I work with for the next year while I'm waiting for these groups. Nothing else happens in that time. COVID hits, working from home. Then I come back to the office just doing the best that I can. 11 months later, so November of 2020, I get a phone call that I can start CBT. Woohoo, that's exciting. My understanding is that this group is supposed to help me and fix me. However, with COVID, it's online. It's an hour and a half once a week. That's it. You tune in, you turn your camera on, you basically do homework, you listen to a 20-minute lesson, they give you new homework, and you go back to your life. If you're ready to be at that point, I'm sure it's great. I was not ready to be there. I was not ready to be that self-motivated. I would do the hour and a half course, I would go back to my life, go back to work, kind of forget about it. I would either lie about doing the homework in the next week, or I would do the homework, but I would spend about 5 minutes and not actually put it into practice. So I keep doing that for a couple months. Obviously, it's not doing much. I'm so frustrated at this point. I can't imagine if this is what it's supposed to be. If this is me being better and this is all the groups that can help me, I'm not sure I want to live like this. This isn't enjoyable to me. Is this how everyone's living? I don't think so, but I don't know. I've returned to work at the beginning of 2021, and a coworker says to me, "Hey, have you thought about going to Homewood? I really think you need to think about that." It's like, what's Homewood? Oh, it's a mental hospital. Yeah, I'm not going there. Over the next couple of weeks, I look at the website, look at 1 page, turn it off. Next day, I'll look at 2 pages and turn it off. Eventually, I get to the point where I've read the whole website and I think, okay, this might not be a bad deal. I can see where maybe I'd be a candidate for it. I'm thinking, okay, I'll fill out the application. I'm sure there's years to wait. I'm not going to get in because by that point, I'll either be better or I'll be dead. Those were kind of my 2 thoughts. So I fill out the application. My social worker fills out her reference, her referral, send it in, wait for 5 weeks, hear nothing, exactly what I expected. It's exactly how I thought it would be. However, 6 weeks in, on my 30th birthday, I get a phone call saying, okay, you've been accepted to IMAP, which is the Integrated Mood and Anxiety Program. You can start in June. My birthday is May 26th. I was not expecting that. I hadn't even told everyone yet that I'd applied. Only a few coworkers and a few friends knew. So I'm very fortunate that my manager is amazing and she helped me navigate that. I figured out when to start, got everything in order, and I started 2 weeks later. So I was in Homewood from the middle of June until the middle of this August. The first couple of weeks were terrifying. I didn't want to leave my room. I had to be almost dragged out by nursing staff. It was not a fun place. The next couple of weeks, I got used to it. I started participating more. I could talk to people. It wasn't that bad. By week 6, I was calling our little unit home. It felt safe. I'd stopped self-harming. I was enjoying being with people and trying to socialize. And the group therapies were helping too. By the end of it, the last couple of weeks, I did not want to leave. I cried every time we talked about leaving. I cried my whole last day. I stayed up the night before. This place had made me feel safe, and everything about it ended up working for me. I understand that that's not the case for everybody, but I'm so grateful that I had the opportunity to go to a place like that. It's so unfortunate that that is not part of our regular healthcare system. You can't go to that if you just have OHIP. It's a private facility. I'm so incredibly grateful that I was able to get in with my work health insurance, but I could not have went there without it. And that breaks my heart because if I would have had to stop at the point where I've done this one group therapy, I think that's it. That's all they told me I can do, and I'm still not happy with life. I don't know what would have happened then. I'm pretty sure I would have bounced in and out of ERs, and who knows how it would have ended up. Instead, I got to go to this amazing program. I met some amazing staff members. I can't even imagine what it would have been like without them. The program itself is great. You do therapy. You do all sorts of things that allow you to work on yourself while getting used to being in life again. We had horticulture and art and ceramics and gym, everything like that while you work on yourself. Lots of spare time learning how to be with yourself, which is really hard to do with anxiety. But for me, it was the staff who really made the difference. So much so actually that I decided I am going to continue on and go to school for being a nurse. So a week after I got out of Homewood, I applied for nursing, and I am starting in January. So I'm very excited that that is what I got out of this journey. I feel like my 30th birthday kind of renewed my life. I got to restart. Not everyone gets that chance. I'm so grateful that I got to, but I had such an incredible support system. I had people with me every step of the way. Before COVID hit, I had someone in the hospital with me every day for hours every day. I couldn't imagine trying to navigate this system alone or without supports that understand or without having all the advantages that I have. It's so scary to me that not everyone has this opportunity. So I hope that you think about that. I hope you can see how you're able to help someone in your life. And just know that the stigma is getting better everywhere I've talked to, everyone I've come out to. The stigma is okay. It hasn't been a negative experience. It's been trying to get help, even when you think you're doing the right thing, that has been more difficult. Thank you.
Wow, thank you so much, Christine. That was incredible to hear about your journey, and I can't even imagine what it was like to go through that. For me, it was helpful to hear, as you said at the beginning, someone from the other side, hearing about all those steps that you went through and, how much you had to wait for the group therapy. And obviously, I think a lot of us know that those 3 to 4 sessions are not enough for many people. So, I mean, I'm so glad that you were able to navigate it, and at the end, you talked about all the support you had in terms of your network, which makes a huge difference. And I know that's the case for our students too. We just have a comment there. Thank you for sharing from one of our attendees. If our attendees do have any questions at all for Christine, feel free to put them in the Q&A and I can publish those as we go along here. We do have a few minutes if there's questions, comments, anything else you want to know about Christine's experiences. And let me also congratulate you on getting into nursing. And I think that's going to be really wonderful. So sad to see you leave campus, but excited for this next journey. And I think it's really, really meaningful work, obviously meaningful for you, especially. So that's really wonderful to hear. Something I was just listening, to you speak the whole time, and I didn't really have time to think of my own questions because I was so captivated by what you were saying. But just thinking back to all of your journey through everything, is there kind of one thing that stands out in terms of either something that you wish existed? I'm sure there's many things you wish existed, or one thing you kind of hope to change in the future, looking ahead to where you want to go and what you want to do now, something that kind of stands out in that regard.
I wish that there was a better roadmap almost so that you understood what was going to happen. I felt like even when I was asking for resources, it was very compartmentalized. You're going to talk to this person, you're going to call this number, talk to this phone number, and they don't know what's going on with the next one. Yep, this is my group, this is what happens. And then I'd say it's not helping or I want to move on. They're like, well, okay, goodbye, good luck. I wish I had known what comes next, what I could do. I would love to help advocate in the future. I would love to help people understand what their options are and that they can get better, that they're not going to be stuck after one thing that didn't work for them.
Yeah, I think that's great. And I know others of us have probably experienced a different kind of way, being on the phone, for example, and having to re-explain your situation, getting transferred around to people. I know our students experience that on campus sometimes too. So I think that's a good takeaway for some of us here. Just taking a look at some other things that have come in. Okay, I'm just going to publish these so we can read them. No questions, just comments. Oh, here's a question here from John. Christine, thank you so much for sharing your experience. How do you feel your experience will affect how you will work as a mental health professional?
I'm actually so excited for that. I think it is the best thing and something that I really learned at Homewood. All the staff members that really resonated with me, that were able to give great advice, were ones that had had their own personal journey. I would really like to work in mental health. I would honestly like to go back and work at Homewood because I know what it feels like. It's one thing to learn about a place, listening to someone talk or learning about it in school, but it is completely different to have experienced it. No one knows what it feels like and what the fear of being in that position is like until you've lived it.
Yeah, absolutely. And I think it's so great that, you're going to be doing this having gone through that experience for that exact same reason. Yeah, lots of positive comments here for sure. Yeah, thank you for sharing. Thank you so much for sharing your story. This is from Sally. Sally's a clinical psych student and have worked on suicide lines as a responder. Stories like yours are far too common in terms of struggle and navigating the system, but so glad you were able to get the help that you needed. And then another post, thank you for sharing your story. You are extremely brave for being here today and sharing.
Thank you.
Yeah. It's such a shame you had to go through all of that. Good to know that you are better and have a plan moving forward. Absolutely. Yeah. Yeah. And then another one, thank you for sharing in such an honest and open way. So I definitely agree with all of these comments. This is not an easy thing to do by any means, especially, having had anxiety and interacting with people in the past. So again, we truly appreciate hearing all of this from you today. And I think that gives us, an inside look as to how we can try and work in the systems that we have to make things better for both students and staff really on campus, and seeing if there's little ways that we can implement and be more empathetic, be more clear about what's going to happen in terms of processes as we're working with people on their different stages of journeys that they're going through. So thank you so much, Christine. If there are any questions that come up, I will be sure to send them on. I don't think there's any more here. Just taking one last look. Oh, we do have, there's one final question, which I believe we have another minute for. So thank you for sharing your story. And can you describe how you felt after taking the first step to reaching out for help?
Well, the first step in that story there, I would think, would be doing that first initial reaching out to EAP and trying to get that first appointment. I had a really hard time with that step because that is the first step they tell you to do, you know, talk to someone, connect with something. And the first thing you have to do with the EAP plan is to call a number and talk to an intake person that's Canada-wide. I am not in a position to just be like, hi, I need help because I'm self-harming and I just came out as a lesbian. It's not something I can just say on the phone. So to try and explain what I actually need and then to go tell a counselor about it is so difficult. Everyone wants you to get help, they want to know, but they don't have time to hear your story. They just want you to tell them right now what you need. And it's so hard to do for some people.
Mm-hmm. We had another question come in. I hope we have time for it quickly here. This person is curious to know how you balanced your mental health with parenting.
It was hard. One of my motivators for going there was my daughter. It's not that I was a bad parent, but I wasn't as emotionally invested as I should have been with her. I was very tired. I wanted to sleep all the time. I didn't, but I wasn't able to engage with her in the way that I wanted to. Sometimes I would have someone come over and watch her because I was just so exhausted. I would be depressed. And she knew it. Even now she knows, but it's amazing. She knows I was at the hospital. She knows they were helping Mummy's head and that I take medicine now. And she's just so great with it. The other day she said, Mummy, do you need a nap? And I said, no, Mummy's good now. I don't need to nap all day. And I'm just very happy now that I can be who I wanted to be for her.
That's awesome. I'm sure she was such an inspiration for you too. And I'm sure she's happy for you and can see how happy you are. With that, we are out of time. So I want to thank you again, Christine, for being here and sharing your story. And I will pass things off to the next moderator coming in today to introduce the next speaker. Look forward to seeing more folks at other sessions. And I'll pass it to Jillian. Thanks.
Hi, everyone. I'm excited to welcome our next speaker, Solana Redway. Her presentation is titled TikTok Diagnosed You with Narcissistic Personality Disorder. Thanks, Solana. Sorry, Solana, let me just read your bio, apologies. So Solana is a third-year undergraduate student at the University of Waterloo. She is currently studying honors science and business in hopes of becoming a pediatric psychiatrist. Solana has been a part of a variety of extracurriculars, including being a part of the Social Innovator program at St. Paul's Greenhouse, where she has and continues to work with a team to assist kids' ability in finding solutions to improve their current management system and initiating programs for kids who have disabilities. To help with this, her team raised $1,000 as a winner of the Social Impact Fund. So thank you so much for being with us today, Solana. We're excited for your presentation.
Okay, so TikTok diagnosed you with narcissistic personality disorder. So I would first like to introduce myself and tell you a little about why I'm here. Like the moderator said, my name is Solana Redway, and I chose this discussion topic because I think it is important to adapt research to reflect what is currently taking place with this generation. I'm able to give my personal perspective on this topic since my father is a diagnosed malignant narcissist, meaning he has been diagnosed with narcissistic personality disorder. So this is the table of contents and briefly what I'm going to go over today. So introduction and my background, and then going into narcissism and then how it relates to TikTok. So my topic. My hypothesis is that pathologizing selfish and self-absorbed behavior furthers the stigma and lack of support for those who actually have NPD, or those affected by NPD. I will be specifically referring to Generation Z and the use of social media, such as TikTok, as a tool used by this generation to develop false images of mental disorders built from generic characteristics and assumptions of the disorder. So what we know. Researchers show that social media platforms such as TikTok have been used as methods for users to self-diagnose themselves with a variety of mental illnesses. The research that is prevalent focuses on ADHD, OCD, autism, and more recently, BPD. For example, a TikTok user claiming to have autism went viral for her reaction to classical music. However, it soon came out that she has been diagnosed herself. She was self-diagnosed herself with autism, and users who actually have diagnosed mental illness issues were very critical for her negative stereotyping of autism. This is just one example out of many similar videos, which may then include the user listing generic characteristics and symptoms that quote unquote must make you have the mental disorder. Looking at some of the statistics to put this into perspective, I found that the hashtag BPD TikTok has 21.6 billion views. Hashtag autism TikTok has 6.3 billion views. Hashtag ADHD has 7.3 billion views, and hashtag OCD has 2.1 billion views, all on TikTok. So from personal use, I have also noticed that TikTok, this TikTok trend has also included narcissistic personality disorder. So examples of these TikToks use the phrasing, if you care about yourself more than others, if you prioritize what you want to do, if you often act selfish, and then usually end with the phrase, you have NPD. These TikTok trends create the idea that if someone is selfish or self-absorbed, they must have NPD. Fixating only on the symptoms of self-importance takes away the focus of other very relevant and prevalent symptoms of NPD, such as but not limited to emotional dysregulation, exploitative behavior, lack of empathy, inappropriate behavior, and unstable relationships. So all of these symptoms I have witnessed in my own relationship with my father, who has been diagnosed with malignant NPD. This type of NPD has additional characteristics, which I've also seen. So such as getting enjoyment from the pain of others, outward aggression towards others, not understanding appropriate boundaries, and being vindictive in situations. When comparing all of these behavioral characteristics my father has displayed over the 17 years I had a relationship with him, the self-centered behavior he showed had a relatively low and negative impact. It was the anger through verbal and physical outbursts, the psychological and emotional abuse, crossing physical boundaries, and many other areas of malignant NPD behaviors that had a greater negative impact on myself and those around him. I normalized the abusive and grooming relationship my father had with me, and it took me almost 17 years to truly understand the parent-daughter relationship I had with him was not at all healthy. So how this may affect us is as a result of my own traumatic personal experience with someone with NPD. I'm very disturbed by these trends because well, particularly on TikTok, by TikTok standards, if I say that my father has NPD, then he is selfish. This is a very limited point of view, such as this view of such a serious personality disorder that can be very harmful to others. This view not only is limiting on the person with the disorder, but also very limiting on the suffering incurred on those around them. So this in turn diminishes the experiences of others and may lead to them not getting the help they may desperately need to recover from the behaviors inflicted upon them. Therefore, these people using TikTok to self-diagnose themselves and those around them discredits individuals who actually are diagnosed with this mental illness, and also often after watching a 60-second video explaining general signs of a mental disorder should not give the viewer authority to then create their own content to further spread these generic stereotypes and disinformation. It becomes kind of like a game of telephone, each video diminishing the impact and lessening the information so that eventually it's watered down so much to be just the characterization of basic terms that diagnose the mental health issue and disorder. So from my own experience with my own mental health diagnosis, I know how much it can make a difference to have a clear answer and understanding of why you have a specific symptom. When you have the mental illness you self-diagnose yourself as or not, it can make you feel valued and give you justification for feeling a certain way. Social media has helped Generation Z to surpass other generations when it comes to communicating about mental health and feeling comfortable sharing their own experiences and feelings. Generation Z, as a result of this, appears to have a higher level of self-awareness and openness to discuss these matters. But at the same time, this generation is also much more likely, as my graph shows, to report their mental health as poor when compared to Generation X and millennials. However, educating this generation on a specific type of mental illness, such as NPD, and what they truly are, versus the false portrayal on the internet is crucial in order for people who have these mental illnesses and those affected by them to get the help and support they need. Just as many doctors advise their patients to not Google physical symptoms in order to try and self-diagnose, the same thing should be said for mental health issues. The internet can be very helpful and informative, however, it's always important to recognize the source of the information. Social media, it should not be viewed or used as this credible source of information. Especially TikTok, where 60% of TikTok users are actually from Generation Z. TikTok, as of September 2021, has around 1 billion monthly active users. This means approximately 600 million individuals from Generation Z are actively using TikTok per month. This is a very impressionable audience, and coupled with the level of open communication amongst Generation Z could make this a dangerous situation for misdiagnosis and misinformation. This is what we have seen with the examples mentioned earlier on TikTok that has unleashed the use of the term narcissistic personality disorder as the general term equivalent to selfish and bossy. So as the majority of these videos only display general characteristics of mental illnesses, it isn't surprising that users do relate to these videos and start to believe they could have the mental illness and that is presented. For example, people get anxious. It does not mean you should be diagnosed with anxiety though. And people get sad. That's a human emotion, but it doesn't mean you have depression. And relating this concept to my topic today, people can be selfish and self-centered, and this doesn't mean you have NPD. Famous theories and models support this, such as Darwin's theory of natural selection and Adam Smith's model of self-interest. Both say that humans act out of their own interest and for their own survival. With the assistance of TikTok, I believe that Generation Z pathologizes general characteristics of mental disorders, which will discredit individuals' experiences and decrease the amount of support for those who need it. Thank you.
Thank you so much, Solana, for your presentation and for sharing how much this topic, impacts you personally. I think it's so valuable. Sometimes we might be aware of trends or things that we see online that we might think are concerning, but it's an important reminder to think about how much of an impact that can have. So I'm just looking through the Q&A and I see one question here. Are you aware of whether specific users are targeted with such videos? And do TikTok users have to search for particular content? So through hashtags and things like that. Can you give a bit of an explanation for people who might not be aware?
So TikTok, it uses an algorithm basically for how long you watch a TikTok, and if you like a specific type of TikTok, like how you interact with a particular TikTok, that's how they know and what to kind of cater towards your feed. So if you are interacting with a lot of, for example, a lot of cats and dogs, like TikToks with a lot of cats and dogs, that means then the TikTok knows this and they'll start showing you on your feed a lot of other TikToks that other users have created with cats and dogs. But you can also search hashtags as well. So it's a combination of the two that you can do, if that helps.
Yeah, I think that is helpful, just to understand too, that if someone expresses an interest in videos about NPD, they may get flooded with information, some of it possibly true, but probably a lot of it not. All right, I'm just looking through the questions. We have another one here. So as someone who has a child with autism, we experience something similar with how stereotypical symptoms are more commonly shared on TikTok, and people don't understand the full story. The spread of misinformation is very frustrated, and thank you for sharing your experiences. And then another message. I think your comment on self-diagnosis can take away resources for people who need them is a very true point. Mental health resources are so limited and so difficult to obtain. My hope is that people will understand that social media does not always represent the truth. So a lot of people agreeing with your messages. And then another comment, great presentation. As a millennial clinical psych student, I see those types of video on TikTok all the time, and I feel very similarly to you about them and the potential harm that they may be causing. I am wondering why you chose to use the DSM-4 criteria for NPD instead of the DSM-5 for your comparison. I don't think it's changed much, if at all. I'm just curious.
If you want my honesty, I couldn't get access to the DSM-5 in time for the presentation. So the only one I was familiar with and I had access to was the 4th edition. And so I really do hope to look at the 5th edition sometime soon, just to compare those and to for my own curiosity. But yeah, I apologize if that.
Great. Well, thank you. I think it sounds like it's quite similar, but it's also a good point to remind us that access to information and the importance of that. So thank you so much, Solana. I think we've reached the end of our time, but we really appreciate you sharing this presentation with us today.
Thank you.
Thank you. So with that, I'm going to welcome our next presenter, Gustavo Betini, who will be presenting the effects of the COVID-19 pandemic on student mental health in Canada. Gustavo is a PhD student in the School of Public Health Systems at the University of Waterloo. He has a PhD in ecology and a lot of experience using observational and experimental data with a number of quantitative tools to investigate how organisms adapt to rapid changes in the environment, such as the ones caused by land use change and climate change. He is now interested in understanding how these same environmental changes impact human health. So thanks very much, Gustavo, for being here with us, and I'll pass it on to you for your presentation.
Hi everyone, thanks for watching my presentation. My name is Gustavo Betini and I'm going to talk about student mental health during the pandemic here in Canada. I think it was very clear after the beginning of the pandemic last year that the general population was going through the mental health problem. If you see levels of anxiety and depression, for example, they were usually higher than the ones reported before the pandemic. So these are two systematic reviews conducted last year showing that the prevalence of things such as anxiety, depression, and stress were around 25 to 30%. There are also many studies like that looking at the student mental health and looking at risk factors such as being female, living arrangements, and history of psychiatric diagnosis. But one thing that we don't have too much is the comparison between a student and the general population to understand if students are at higher risk than the general population. And that's the goal of the study, is to understand if anxiety and depression in students is higher or lower than those observed among the general population during the pandemic, but after you consider other socioeconomic variables that has been shown to be important, such as social income and gender. To do that, we're going to use data from Mental Health Research Canada, which is institution based in Toronto that's dedicated to understand the mental health of Canadians. Since last year, beginning April, they started a national polling project. So these are online surveys that are conducted every 6 to 8 weeks. As I said, the first one was end of April, the last one was end of August this year. For this analysis, I'm going to use just 7 polls, so between August last year and August this year. So we have 8 in totals, but I'm going to use only 7. And all the results are weighted by age, gender, region, according to the newest data from Statistics Canada. And the response rate is around 40%. The outcome that we use is self-reported anxiety and depression scale that goes from 0 to 10. So we just ask people from 0 to 10, what's your level of anxiety and depression? We compare the self-reported scale with the GAD-7 and PHQ-9 for anxiety and depression that are well-known scales that have been used for a little while. The correlations are 0.61 and 0.68 respectively, but we don't have too much data. We have just one poll that these questions were asked. But we have much more data from the Kessler-10, which is an index that combines both anxiety and depression, and as you can see, the correlation is quite high, it's 0.92. So that kind of gives us confidence that what we are measuring in terms of anxiety and depression is it goes in the same direction as other well-known scales used in the field. These are the distribution of anxiety and depression that we see in the data. We divided, for the purpose of that analysis, we divided these into zeros and ones. So if a person answer anything about from anxiety, depression, this scale from 0 to 5, we assign a value of 0, and from 5 to 10, 1. And this way we can use logistic regression in a 2-steps approach. We first use a bivariable logistic regression, so response variable is just the anxiety or the depression scale, and then we look at student status, we look at gender, we look at income. And then we put all these risk factors that we analyze into the same model to calculate the adjusted odds ratio. So to look at the student status after controlling for income and gender and other things. And I'm going to go straight to the results. So these are our population. Around 17,000 people answered our poll. You can see that the gender balance is quite good, is representative of what we have in Canada, but the age and the student status are fairly disproportionately distributed here. So you have 10% of people that are between 18 and 25 years old, and you have only 6% of the population that are students. Though the percentages are quite different, the sample size are still quite high. So, for example, we have a little bit over 1,000 students who answer our poll. which is more than enough to conduct the analysis that we wanted. So our first interest to understand the isolated effects of each of these variables that we use. And I'm going to go slowly here because I'm going to show another plot that's similar to that one. So these are results for the bivariable analysis looking at anxiety since COVID-19. Okay, and you see in the y-axis the risk factors that we used, and the x-axis that's the odds ratio. So beginning with the first one in blue, we have the diagnosis before COVID. So people were up to 6 times more likely to experience anxiety since COVID if they had a diagnosis of anxiety before COVID. Another result that is not a surprise, that age is a risk factor. So older people, or 25 years or older, not older people, they are less likely to experience anxiety. So young people are more likely, which is a result that I have seen in many other studies. Living arrangements is quite interesting. The reference value here is living with your family, parents usually, and that's not different from living with roommates. But if you live alone or you have other living arrangements, you're less likely to experience anxiety. Income, it wasn't a surprise. The reference value is $30,000 a year, your income or your household income, and the more money you make, the less anxious you are. Female and student status are significant and have a odds ratio around 2, so we're around 2 times more likely to experience anxiety since COVID if you were female or a student. Now, when you put all of these variables in the same model, things change a little bit. We still have the diagnosis before COVID as the strongest predictor here, so odds ratio is a little bit lower than 6, but it's still very strong. But the big difference that we see here is the change in the odds ratio being female becomes smaller, is still significant, but the student status now, it's not significant. So if you repeat this analysis with depression, we're going to see exactly the same patterns. And in the interest of time, I'm not going to present the results for depression. So in some way, this was surprising because there's so many discussions about the student mental health of people that are going through a difficult time during COVID-19, that I was pretty sure that the student status was going to be a risk factor. So this is good news. It doesn't seem that being a student is necessarily a problem, but as we saw, younger people are at higher risk. And of course, you were probably asking, but how many people between 18 and 25 that are not students? And that's a good question. I don't think we have sample size enough to look at that, although I reran this analysis just for that group of 18 to 25, and then student status is even less important. But I would hold these results for now because I think we still need a sample size a little bit larger to reach that conclusion. But the big surprise here was the diagnosis. So you are up to 6 times more likely to experience anxiety and depression if you had a diagnosis of anxiety and depression before COVID. Living arrangements is a little bit more complicated to understand because it's not clear if people that live with family are more anxious or depressed, or they end up going to live with their family because they were anxious and depressed before. So we don't know the direction of causality here. And the female and the income, which are fairly common results that have been seen in other studies of mental health during the pandemic, which is a good thing that gives confidence that we're going to the right direction. Thank you.
Thanks very much, Gustavo, for a really interesting presentation. I think it gave a lot of us to think about impact of the pandemic on the mental health of students, and thinking about the other risk factors that have that are there for students and for others as well. As I was watching your presentation, I guess one thing that surprised me, you spoke a little bit about it towards the end of your presentation, was that people who were living with other people had higher levels of anxiety and depression. And I think there was a narrative, or at least that I heard, that if you lived alone, you might be more likely to suffer, for your mental health to suffer because of feelings of isolation and loneliness. So do you have any insight, any further insight into why we're not seeing that, what we might have expected?
Yeah, that's a great question. And I need to apologize. We need to record in my presentation because I wasn't sure if I was able to be here. And I had to sit here and painfully watch myself presenting for 10 minutes. That's a horrible experience. Yeah, I think it's a great question. That was one of the motivations to start that study very early in the studies of mental health and COVID. There was that idea that young people between 18 to 25, 18 to 29, they were they're suffering more the consequences of the COVID. A lot of people talk about student mental health, and that question became, oh well, but of course, if you're living by yourself in an apartment, in a small apartment, and then everything is locked down, you cannot see family, you cannot see friends, this is going to increase your stress. But there's another story here that you can tell as well, which is, well, you spend all your day, before COVID, you spend all your day out. You are in class, you are doing other activities, you're doing sports and meeting with friends, and now we're stuck with roommates that you barely know. So we don't know exactly which was the direction, what was the direction that we're going to go in. It seems that living with the roommates, it's something that increases the anxiety and depression in people. But I think it could be easily the case that we'll find, depending on if you're changing the population, we could find something different there. I don't think we have too many studies there to say that one thing is more likely than the other.
Right. So we'll see as more information, as more data comes in, we'll see if that continues. Thank you. There's a question posed in the chat. Out of curiosity, why was logistic regression and dichotomization used instead of linear regression, given that the outcome variable was continuous, self-reported depression / anxiety symptoms?
Yeah, it's a good question. It's more a tradition in the field that I think odds ratio gives a nice, simple story to tell than the linear regression, where we would need to present some kind of estimate and say that, you know, today's slope is, I don't know, 1.2 or 2 or 3 or whatever. It's more difficult for people to understand, but how much more likely or less likely that females or students are to experience anxiety and depression since COVID. That was the only reason. I haven't done, but it's a good idea actually to redo the whole analysis and see if we get the same results. We should actually. Thanks for your question.
Okay, I guess another thought that I was having as I was listening to your presentation was about kind of the implications for supports for anxiety and depression for students, and understanding all of the different factors that have impacted on students and have maybe made them more or less likely to experience anxiety and depression during the pandemic. Do you have any thoughts on how this information could be used to inform the organization of supports for students?
Yeah, I think so. I think in terms of recommendations and how to support students, the fact that the students are not a risk factor is not very essential because most students are between 18 and 24. So the risk factors that we found apply for students as well. So we should be looking at people with a history of diagnosis of anxiety and depression. That's very important. Apparently, according to the results, is the most important one. So that maybe we should start there. Female, it seems to be a common result in many of these mental health studies on COVID that being female, it's a risk factor. And maybe living arrangements, something that maybe an university could do with the living arrangements inside of the campus, right? Statistically or more analytically, I try to look at the interaction. So I try to ask, okay, are younger students more likely to experience anxiety and depression than younger students? I didn't find anything there. But also we have small sample size, so I didn't want to talk about that because I don't think the results are robust enough that we can discuss. But that's something that in the future is important to support the students. For example, maybe older students are more anxious because of the pressure of finishing and going on with their lives and trying to balance working and student and this and the school at the same time, or it could be exactly the opposite. So I don't know.
No, I think that. Thank you. I think that's really interesting, and it makes me wonder too about just the wider implications, even when we're not focusing on the experiences during the pandemic, but the experiences of students and the wider population of anxiety and depression long term. I don't see any further questions. Did you have any other comments you wanted to share with us before we break?
No, I think the questions were great. Thanks for the opportunity to talk a little bit more about that. And this is an ongoing project that I think I want to highlight that's an ongoing project. We have 7 or 8 more polls, so we will double the sample size that we have here, and we will have a much better chance to look at some of these more fine scale questions that could be used to support student mental health here in Waterloo.
Okay, great. So hopefully we'll see you for next year's conference, and you can share the results once you get the rest of that data in.
Yeah, for sure. Great idea. Thank you so much.
Thank you. All right, everyone. I just want to thank all of the participants this morning. It's been, I think, a really interesting and dynamic morning. And so thank you everyone who was able to join us. We are going to break for lunch now. So when you return at 1 o'clock, you can use the same link that you used to join this morning, so that you'll arrive right into the same place. So please enjoy a lunch break now, and we look forward to seeing you all again at 1 o'clock. Thank you.
Welcome back, everyone. I'd like to welcome you back from what was hopefully a restful break away from your computer and your screen. A couple of reminders as we get back into it. For anyone in need or looking for resources for support, we're going to put the resources in the chat. Also a reminder, if you have any questions, to put them right into the presentation. At the end of each presentation, a moderator will pop on and we will ask the presentation or the presenters. Okay, so with that, let's jump right into it. So our next presentation is entitled Performance Measurement Systems for Mental Health in Universities, presented by Dr. John Hurdies. Dr. Hurdies is a professor in the School of Public Health and Health Systems at the University of Waterloo. He served as our chair of the university's Committee on Student Mental Health, COSMH. In addition, he is the Senior Canadian Fellow and a board member of the at www.interrai.org, an international consortium of researchers from over 35 countries. He chairs Interai's Network for Mental Health and the Interai Network of Canada. As well, Dr. Hurdies is a fellow of the Canadian Academy of Health Sciences. Dr. Hurdies has over 230 publications in peer-reviewed journals and academic book chapters. His primary areas of interest include assessment, mental health, aging, healthcare and service delivery, case mix systems, quality measurement, health information management, and quantitative research methods. In 2012, Dr. Hurdies received the Queen Elizabeth II Diamond Jubilee Medal for his work on long-term care through the Canadian Home Care Association and the Canadian Association of Gerontology. It is my pleasure to pass this over to Dr. Hurdies.
Great, thank you very much. And I think I'm going to be doing a screen share for my slides, if that's correct. Okay, so are folks seeing my slides okay? Donna, are you able to see my slides okay?
Yes, we can see them.
Okay, perfect. Thank you everybody for having me this afternoon. I want to pass on my congratulations to everybody involved in the organization of this event. It's great to see that we've had our second annual event for this important conference, and wonderful to see that some of the work that we started with the Committee on Student Mental Health has got legs to it to continue on to engage the campus community. So thank you to all of you who have been involved in organizing this year's events. This morning's session was a great session, great variety of presentations, very inspiring and interesting work and perspectives offered there. My presentation is going to switch a little bit in its focus to be a bit more oriented toward health services research in mental health and thinking about how some of that work can be applied to a university context. I'm going to draw from my experience as somebody who's worked in health services for over 30 years and my observations that I had while chair of the Committee on Student Mental Health on some things that I thought the university could do to improve its capacity to enhance student mental health by introducing performance measurement systems and to evaluate the effectiveness of universities in supporting student mental health. And this presentation is intended to be a basic starting point to make some initial observations and some suggestions. It certainly is not the end point where all the answers will be presented. So what I'd like to do is first of all talk about the two key initiatives that really influence, I think, how universities need to think about student mental health at organization levels. And then also have a brief discussion about what aspects of life in the university affect student mental health directly. I'll give you a bit of an overview of performance measurement systems, what would need to go in there, and draw from my experience in a couple of other settings to show you what is feasible elsewhere that we could be thinking about in a university context. And then I'll end with some with a question about what do we have on hand now and what do we need to be able to move forward. So if we think about the work of the President's Advisory Committee on Student Mental Health and the Committee on Student Mental Health that was the implementation committee for the PAC SMH report, one of the key documents that was pointed to in both reports was the Okanagan Charter, which is an international charter for health promoting universities and colleges that guides how these organizations need to think about health and well-being, including mental health. And so COSM, the committee I chaired, and Campus Wellness worked together in order to implement that recommendation number 34 of the PAC SMH report that says we need to adopt and promote the use of the Okanagan Charter at the University of Waterloo. And so on November 2nd, 2018, the university became an official signatory to that charter, and that's process of signing on committed us to undertaking a variety of different activities. And one of those things we committed to was to develop mental health metrics and broader measures of health and wellness for evaluating programs or services and reporting on the university's continuous progress toward improved outcomes related to health and wellness. To do that, we need to have a performance measurement system in place. The other document that is very relevant here is a new standard that's been released related to student mental health that was done by the Canadian Standards Association, the Standards Council of Canada, and the Mental Health Commission of Canada. I served as a member of that expert committee. This was about 2 to 3 years worth of work to come up with this standard, and there was very broad engagement of stakeholders from across the country in this effort. And the intent behind this standard is that post-secondary institutions should use it to develop and implement and enhance and sustain mental health and well-being framework using a socio-ecological approach to support health, a health and safe environment. And in it, there's a requirement that organizations that are confirmed to be adhering to the standard will have an evaluation framework in place so that we can evaluate the performance and effectiveness of the mental health framework being used in the university, and that includes measurement of structures and processes and outcomes of policy initiatives and mental health services using both qualitative and quantitative measures. So both of these critical documents around student mental health call for having an evaluative framework in place and measurement systems to be able to get at information about student mental health. So a starting point is to think about, well, what are the factors that affect life on campus and affect student mental health? And really, every aspect of our work and collaboration on campus is relevant. And so that's why the PAC-SMH report, which had 36 different recommendations, was very broad in its nature in terms of what it covered, because your experience in the classroom will affect mental health, your relationships with supervisors, if you're a graduate student, with your peers, for any student, your experience on a co-op placement will be relevant. And then there's services on campus, like housing will be relevant, and campus police services would be another group that has a role in overall student mental health and well-being. So really, every part of the university can have an impact on or can influence student mental health. And so the PAC-SMH report and the COSM work to implement that report really implemented a very broad range of recommendations to touch on all of these different aspects of life on campus. And then there are specific mental health services on campus that are relevant. So we have counseling services on campus. We have a complex case management team for persons with severe and persistent mental illness. We also have a Center for Mental Health Research and Treatment. I put an asterisk beside that because that's not necessarily a service dedicated to students only. Probably some of their client base includes students, but it's not only a student mental health service. And then we have off-campus partners that are involved in different aspects of mental health as well. So we have community mental health and addiction services in the broad-based community. There are mental health units in general hospitals, as well as standalone specialty hospitals like Homewood. There are private pay counseling and therapy services. And then there are agencies like Waterloo Regional Police Service that are doing a great deal around how they interact with persons with mental illness that we also need to think about in terms of how we relate to their involvement in the system as well. And a key thing for all of this, and a really important message, is that we really need to think about system integration and collaboration of all these different partners so that everybody that interacts with persons experiencing mental health concerns, or everybody who can influence the mental health of students and other members of our community, knows how to work together, collaborates effectively, and can share information appropriately. So let's think about what a performance measurement system is. If you read this literature, there's a huge amount of variability of what people are talking about when they're talking about performance measurement systems, but there are some key concepts that come into play here. The first is that there's use of aggregated data to understand the experience of populations of service recipients. So it's not necessarily about individual case-by-case experiences as much as what's happening overall among all service recipients. There's a focus on standardization of measures so that you have comparable data and comparable indicators across different settings and over time. And the focus is on really all major aspects of the performance of the organization, including cost measures, measures of the quality of services being provided, the efficiency of services, the resources that are being allocated, how they're organized, and so on. And the important use of this system is to inform decision making by senior officials, so folks in administrative or service delivery positions or policy positions would use it to inform judgment about how well the system is performing overall. But it's also really important from a transparency and public accountability point of view that individuals, students, family members, faculty, staff, administrators, anybody in the organization should be able to see how well we're doing with respect to an issue like student mental health. If we go to the healthcare literature, there's really two main frameworks that you'll hear about in terms of performance measurement. Historically, the most well-known model is something called the Donnovan model of healthcare quality. And Donnovan was a University of Michigan researcher. He introduced the idea of indicators of three main factors affecting quality. So one is structure indicators that look at how services are organized, the resources allocated to it, the capacity of the system to provide supports. So an example of a structure indicator would be the ratio of mental health staff to students on campus would be a structural indicator. Then there are process indicators that really relate to the actions that the organization takes to either improve or maintain health. And so this can include things like the types of therapies or counseling being provided. The approach to clinical evaluation would be another example. And then there are outcome indicators that look at how the person changes over time. This could include the experience of different events, changes in the severity of illness, the maintenance of well-being. And for me, I'm always interested in outcome indicators ultimately, because that's what the performance of the system should ultimately be about, is are you getting better and are you able to lead the life you want to lead? A more current framework, though, is the Institute for Healthcare Improvement value-based care model, which uses what they call a quadruple aim for healthcare. And in that context, they talk about an improvement in the patient experience. So how do people feel about the care that they receive? Getting better outcomes. Did health get better? But they also talk about staff experience, and this is important because I think if we think about a university and student mental health, also understanding the well-being of faculty and staff will be an important consideration with this also. And then the quadruple aim also considers cost to look at can we manage cost without compromising quality overall. So I'll give you a couple examples that I'm familiar with that I've worked on over the course of my career. One is from the Canadian Institute for Health Information. They have a public reporting system called Your Health System that reports on the performance of different types of healthcare organizations in terms of the quality of care being provided. So I was involved in designing the performance indicator framework for long-term care homes. So today you can find any long-term care home in Ontario and 1,500 different long-term care homes across the country. You can look them up online and say, okay, well, who are the people that are being served there? What are their diagnostic characteristics? What's their age distribution? And so on. And you can get information about the lives and the quality of care provided to residents in that home, including mental health indicators. So in this case, this is a long-term care home in the town or the region I live in Elora. This is a Crescent Care in Fergus. And this is an indicator of the percentage of residents whose mood worsened in terms of depressive mood over a 3-month period. And you can see the rate for Crescent Care was around 29.9% compared to 30% in their chain, 25% in the Waterloo, Wellington, Lynn, 22% in the province, and 21% in the country. So in these homes that receive relatively few resources, we have a very precise and comparable measure of mental health in terms of mood that we can do local, national, and in fact, international comparisons on. CIHI also produces reports on things like wait times for access to counseling services in the community. So in the general population, about 10% of people wait more than 4 months for access to community-based counseling services, and many of them wait about halfway for a month for access to community services. So wait times is an important issue for community mental health services overall. If I think about examples of questions that we should all be able to answer for the University of Waterloo around mental health services, some examples of questions that we should have information readily available to us are things like, what are the most common mental health concerns affecting our students? Why do students access mental health services on and off campus? What are the rates of improvement for people receiving those services, and how does that compare to other universities? Do students have better outcomes in our counseling services compared to other university counseling services, and how cost effective are the services that we're providing? How often do our students need access to inpatient mental health beds? What proportion of students come into contact with police officers as a result of serious mental health concerns where public safety considerations are involved? And how many students are shared clients with agencies like the Canadian Mental Health Association? How well does our university culture support overall mental health and well-being? And how well do our services support recovery among students dealing with mental health and addictions issues? If we think lastly about the information we have and what we need to have, well, here are some examples of things we already have available to us that we could use in a publicly reported performance measurement system. We have structural measures like the ratio of mental health staff to students that we have readily available to us. There are also surveys that are done routinely that give information about student mental health and well-being. A challenge there is that the response rates might make it difficult to do effective benchmarking between universities in a way that is actionable. We can calculate wait times for access to mental health services, but it's got to be done. It takes a fair bit of work to get it done. It's not as automated as I'd like to see it. And then we do things like student course evaluations that actually could lend themselves for use as indicators of how well we create an environment that's supportive of student mental health and well-being. What we don't really have are standardized clinical information systems that identify the strengths, preferences, and needs of mental health service recipients. We don't really, in a systematic way, track and report on clinical outcomes. And we don't have a very well integrated system of information clinically with our partners in care, like the hospital settings or CMHA. And I don't believe we really have a fully fledged system to look at the person's experience with mental health services on campus. So those are some areas we should start to have a discussion and explore what we might do to have a more robust and comprehensive picture of the overall performance of our student mental health system. And so with that, I'll end and happily take questions and comments if there's time.
Dr. Hurdy, thank you so much. As we were going through, I was thinking of questions that I had, and then you put up a slide of all of the questions, and I think most of them were right on there. So you mentioned an important consideration being system integration and collaboration on our campus. I feel like there are a lot of staff currently working on that. Do you have a vision of what that looks like or what that could be?
Yeah, so I think it's one of the things that we need to do is realize that the university is part of a mental health service provision ecosystem, that we provide a lot of mental health services on campus, but some of those service recipients also get mental health services from the hospital system, from private counseling services in the community, and from the CMHA. And so if we're to look at it from the person's perspective, having integration and collaboration among all those partners could help improve the effectiveness of our system and continuity of the supports that folks could be providing.
Thank you. I agree with that. And I think that aligns with some of the presentations that we've heard previously this morning very, very well. Do you have any insight on what makes our campus unique when we're talking about the University of Waterloo specifically?
Yeah. So I, along with many of the colleagues that organized this event, served on the Committee on Student Mental Health for 3 years, and I also served on that Mental Health Commission of Canada report on the CSA standard for mental health. So I got a pretty good deep dive into what the university is doing and how that compares with other universities. And so the good news is that the University of Waterloo is actually quite far ahead in thinking about student mental health and the holistic approach we need to address all aspects of student mental health. And you know, my experience on the Mental Health Commission committee that included people from all coast to coast to coast was that we were ahead of most other universities in terms of what we are doing now. But we should not be complacent, and we should not kid ourselves that we have all the answers yet. There's still lots of things we need to do to continue to improve our systems overall.
That's fantastic. One last question, and then if anyone else has questions after the fact, we will pass them along. But last question for now, how do you share or disseminate the findings or answers to these questions that you have?
Well, the example that I gave you of the nursing home side of things, you can go on, everybody online can go on to Google right now and go yourhealthsystem.ca and type in the name of a long-term care home, 1,500 of them in the country, and get direct information about the performance of those homes, about on those quality indicators. That's the vision that I would have ultimately, that we would have a pan-Canadian university system where you can see how student mental health is doing in any university across the country. It's a scary thing when people start to think about it first, because from an administrator's point of view is, my goodness, you're going to have information about our quality publicly. Well, 1,500 nursing homes have gotten over the fear of being publicly accountable, and it's fine. It actually helps to improve the system overall. And so, but it takes time to get there. That was about a 10-year collaborative effort to get long-term care to that point in the country.
Wow. Okay, well, while I am very proud of what we have been doing, it sounds like we still have a lot of work to do. On behalf of everyone attending today, I would like to thank you very much for sharing your research and expertise with us, and have a wonderful day.
All right, thank you, everybody.
All right, on to our next presentation. So our next one is called Key Takeaways from Waterloo's Undergraduate Mental Health Literacy course, presented by Christine Zaza. Christine Zaza, PhD, is an adjunct lecturer in the Faculty of Health and an online learning consultant in the Center for Teaching Excellence. Her areas of expertise include accessibility, mental health literacy, and universal design for learning. To address concerns around student mental health, in 2018, Christine proposed an undergraduate course on mental health literacy for all students on campus. She subsequently designed the course and taught it for the first time in winter 2020. So welcome, Christine, and I will pass it over to you.
Thank you. Happy to be here today presenting. Thank you for this opportunity to present at this amazing conference. Hopefully you can see my slides. Okay, if somebody could please confirm.
Yes, we can see them.
Okay, awesome. So thankfully, I'm having this opportunity to present some key takeaways from this course, and I'm presenting today on behalf of Gitanjali Shanbag, who was not able to make it today. So I'd like to start by acknowledging that this research was funded by a Learning Innovation and Teaching Enhancement grant from the Center for Teaching Excellence. To help us understand the context of the research findings, here's a little bit of a background about the course. So in December of 2018, I proposed an undergraduate mental health literacy course to the Faculty of Health so that students could earn a credit for learning how to care for their mental wellness and help others as well. Since 2020, the AHS 105, mental health literacy, has been offered in 5 terms so far. You can see that in 2021, it's been offered every term and with 2 sections per term. By the end of this term, approximately 800 students will have gone through the course. And my understanding is that over 400 students have pre-selected the course for winter. So I'm crossing my fingers that there'll be more than 2 sections next term. I'm not going to go through this in great detail, but this concept map that I use in the course, that I developed for the course, will show you some of the topics, the key topics and components of mental health literacy that are covered in the course, from knowledge to stigma, help seeking, helping others, and prevention. So here are 2 key characteristics of the course. One is that there are 2 themes running throughout the course. One theme is looking inward, where students apply course concepts to their own mental well-being. And one is looking outward, where they apply course concepts to their community, their campus community in particular. The assessments of the course focus on the application of concepts. Through a personal mental wellness project, students they have the opportunity to try out and then evaluate various mental wellness strategies, such as mindful breathing, journaling, gratitude, exercise, and their choice from a menu of selections. And then the group activities are focused on applying mental health literacy in the campus community. So now I'll move on to presenting the research. And here's a snapshot of the research that has been done so far in the course. So Ryan Young took the lead on conducting pre-post studies right from the beginning, the very first offer of this course in winter 2020. And this year, Gitanjali Shanbag took the lead in proposing our Light Grant proposal, which we received. And that was to look at the evaluation of to evaluate the final assignment, which is a reflection. We also have a 1-month follow-up study planned a month after the end of the fall term. So all of our research received ethics clearance, and today I'm going to be focusing on the results of the evaluation of the final assignment. So the final assignment, part 1, included 3 questions. In the first question, students were asked to reflect on their achievement of course level learning outcomes and identify the one outcome that they felt the most confident in achieving and explain why. In question 2, students were asked to reflect on the looking inward key takeaways. They were presented with my 5 key takeaways for the course, and they were asked to then reflect on which one they felt was the most meaningful to them. Same thing with the looking outward takeaways. And for these 2 questions, students were prompted to use the questions what, now what, so what, and now what, to really get into what did you learn, why does this matter, how has this changed your previous assumptions or behaviors, and what will you do differently, how will you apply what you learn. So we had 2 approaches to analysis. We conducted a manual content analysis looking at each question individually as well as all 3 questions together. And independent of that, Ryan Young conducted a structural topic modeling procedure where it's a computational technique that is a form of unsupervised machine learning that uses observed documents to infer hidden topic structures. And I think if Ryan were here, he could explain that much better than I just did. So our sample included 32 final assignments. The average year of study was 3.3 years, and the average age was 20.7. Keep in mind that the spring term, there would have not have been first-year students, so we had more upper-year students. 88% of the sample identified as female, and we had students from every single faculty in our sample. So now I'd like to move on to our findings. As far as the course level learning outcomes, there were 3 that stood out as being the most, students felt the most confident in achieving. The first one related to the application of course concepts to students' own mental well-being. The second related to stigma around mental health. And the third related to recognizing signs, symptoms, and treatments for common mental health conditions that were covered in the course. And you can see the other learning outcomes that they had here as well. S21 denotes the 2 extra or other learning outcomes that were added in spring. The structural topic modeling analysis revealed this relative frequency graph, which shows that the words apply, stigma, help, well-being, outcome, and feel were among the most frequently used. And that shows good consistency with the other type of analysis that we used. In terms of the looking inward key takeaways, 59% of the students identified prioritizing mental health is a need to have, not a nice to have, as their most meaningful takeaway. And 22% referred to the looking inward takeaway related to resilience. And you can see the other 3 takeaways that are presented there. The structural topic modeling relative frequency chart shows that the words need, time, take, and resilience were the most frequently used. So that again shows good consistency with the manual analysis. In terms of the looking outward takeaways, 34% of students identified recognize, respond with empathy, and refer as their most meaningful takeaway. 34% identified respecting personal boundaries as their key takeaway, and 22% talked about how identifying and reducing mental illness stigma was their most meaningful takeaway. And there's the other ones that were presented. And the structural modeling topic modeling shows that the words boundary, stigma, and help were the most frequently used. And here's a word cloud that was generated from the structural topic modeling. And this word cloud shows the prominence of the words resilience, outcome, prioritize, feel, help, boundary, and stigma, conversation. So a lot of important words that students are using in their assignment. So some key findings looking across all three questions. Students' responses demonstrated positive and very meaningful shifts in their knowledge, attitude, and behavior regarding mental health problems, including stigma, self-care, helping others, and resilience. Students were applying what they learned above and beyond the requirements of the course. I would expect students to talk about how they applied the concepts because that's what they were graded on in their assignments. However, they went above and beyond that, and we'll take a look at some examples of that. Also, it was evident to me that students' responses demonstrated a strong level of mental health literacy. And I noticed that in particular because they were using words like culture, intersectionality, unconscious bias, a lot of important topics that were covered in the course. And I did not see that a year ago before I had made some significant changes to the course. So I'd like to show you some quotes that illustrate the shifts in mental health and stigma. Before taking the course, I'll just read the quotes. Before taking this course, I had not realized how many misconceptions and assumptions I had about various mental illnesses and mental health concerns. I quickly realized I had a lot of unconscious biases. Prior to taking this course, I really didn't understand how significant structural stigma is. And then through the course, I now try to challenge any preconceptions I have. I have less fear and more compassion now. I now realize that in the past, some of my beliefs and attitudes regarding individuals with mental illness have contributed to social stigma. With regard to shifts in self-care, students describe not making the time to care for their mental health before the course. This one quote, I think, sums it up well. I believed the sole method to reach success and find happiness required sacrifice of subjective well-being. And then through the course, one student said, this course has changed my perspective and previous assumptions in that I now understand there is no shame in being selfish and setting boundaries in life to protect my own wellness. I realized that my tendencies to cope were unhealthy. In terms of shifts related to helping others, before taking the course, students were responding to others to the extent that their own mental health was being negatively impacted. This came across in a number of students' responses. One student said, I became people's therapist. Another said, my previous assumptions about responding to others included being there for them all the time. And this is exactly what a number of students described, 24/7 responding to friends who were having mental health issues. Some other students were talking about how they were unaware of how to respond before the course. Previously, I did not know how to open conversations about mental health with my friends when I was concerned, often avoiding the topic or giving unprompted advice. And then through the course, now students were feeling able to set and respect boundaries. I am not anyone's therapist. I shouldn't replace the role of any professional worker. They were able to start conversations and connect friends to mental health services. So this showed me that not only were they responding, they were also now able to refer. Many students talked about recognizing the immense impact of their words. This course taught me not to label. I also learned to be aware of how unique identities, culture, religion, gender, etc., can intersect and shape each person's experience with mental health concerns. Another student said, this course taught me to really stop and think before just saying the first thing that comes to mind. In terms of resilience, before taking the course, they had a different perspective of resilience. One student said, I was previously under the impression resilience was something that some people had or had more of and others did not, as if it was a personality trait through nature and nurture I just did not happen to receive. One student said, I used to think resilience meant sucking it up. Another said, I thought I was not bouncing back quick enough, burnt out too often, was lazy. I used to think I was weak, and I used to blame myself for not being able to just bounce back faster like everybody else. And then through the course, they were talking about how they now recognize that they don't need to bounce back quickly. That's not what resilience means. My biggest takeaway was learning that I'm more resilient than I thought I was. When asked to write my resiliency story for assignment 3, I felt very proud of myself. This was the first time I had truly told my story, while also having the opportunity to recognize my resiliency on a level that I never had before. So this showed me that students were understanding the model of resilience presented in the course. Here are some examples of how students are applying their mental health literacy over and above the requirements of the assignments. They're scheduling alone time in their calendar. One student said, just to recharge, just so I can be alone. Using breathing techniques before a test and seeing that helped them to focus. Using self-compassion rather than judgment. Decreasing time spent on social media, another topic in the course. Broadening spiritual well-being, reframing school-related stress. Using campus services that they were previously unaware of. And in their community, one student talked about how she explained stigma to her parents and explained why a family member who lives with depression hid his symptoms. She went on for a paragraph describing how meaningful that was. It was quite moving. Another student talked about how she introduced mindful breathing to her study group. Another talked about starting a weekly self-care night with a sibling. A student talked about creating a safety plan with a friend. That's something that we did in the course, and connecting that friend to health services. Another student talked about reaching out to friends just to check in to show that they care, something else we talked about in the course. And more than one student talked about preparing proposals for new community groups or student groups. So briefly, I'll just mention some next steps for AHS 105. As the course author, I continue to review and revise the course level learning outcomes and key takeaways for future terms, and I will be referring to these data as I do so for the winter term. Future research is in the works. We are planning to, I would love to plan to continue to build the evidence base for this course. I feel it's really important. And I'm in the middle of completing an eCampus Ontario funded project to share this course under a Creative Commons license with other Ontario post-secondary schools. This is a project that my colleague Julia Burke initiated. She took the lead in proposing this idea and preparing the proposal to eCampus Ontario. We were successful and we're now in the later stages of finishing this project. This gave us funding to have a peer review of the course, have an EDI review of the course, invite guest speakers, including an Indigenous guest speaker, and to increase the interactive elements in the course. So we have 14 post-secondary schools in Ontario who are planning to offer this course as early as next year. Hopefully that will open the door to some multi-state studies. In terms of final words, I'd like to leave the final words from the students who participated in the study with these two quotes. I am no longer ashamed of mental health disorders. Since I understand myself better, I find it easier to talk to a healthcare professional. I did not understand how my own internalized stigma was impacting my mental health or how it contributed to my reluctance to seek professional help last year. Now I understand that I have not failed if I need extra support. I have not failed if I get professional help, and I have not failed if I have a mental health issue. Thank you.
Thank you so much. I think the work covered in this course is so important, and especially at such an important time in our students' lives. I encourage people to pop their questions into the Q&A. We heard a lot about the students' feedback, but I've also heard some excitement around campus. Can you share the feedback that you've received from staff and faculty?
So when I was teaching the course, I probably heard a bit more of that. I think I've heard that this course was announced to a number of academic advisors on campus, and I've heard from some of them. Some of them have taken the course, and I've heard that they have found it really helpful in their work with students. I think that the course has been really well supported, and there's a lot of excitement about the course in the Faculty of Health, and I'm really grateful for the support and the faculty for this course. And beyond that, I've taken a step back from teaching it because there's no way in my role as a staff member that I could possibly teach 2 sections every term. But I think it's in good hands with Gitanjali Shanbag and Renate Donnovan, who are the course instructors right now.
That's great. One of the questions coming through the Q&A is, do you see this course being taught in other post-secondary institutions?
Yes, so in the previous to the last slide, 14 post-secondary institutions are set up to teach this course in their own schools as early as next year. I'm just off the top of my head, I know one of them is Wilfrid Laurier, York. We're in conversations with York about this, and there's 2 other universities, and then the rest are colleges who are very keen to offer this course.
Within that, do they take the course as is, as here's the framework, or would they adapt it to their own university audience?
So with the Creative Commons license we have, they are taking the entire course. We have some guest speakers who have given us permission to use it in this course with the knowledge that others may be using it. There are lots of links across the course, a number of in every module, there's that link to looking inward and looking outward and reference to other materials. So the idea is that a school would take the entire course. If they want to adapt it or make some changes, they just need to talk to me first because I'm the rights holder for the content. They can, we're giving them an instructor's handbook as well as a menu of assessments that they can choose from or adapt to their own needs. So there's some flexibility there, but my concern is that if it gets really dissected and it could lose the original intent behind it. So there's some checks and balances there.
And once it's shared, are you still able to capture the metrics around it, or to be determined? Okay.
That's to be determined. I'm really hoping that by sharing the course widely, it opens the door to some multi-site studies that would be really nice to see so that we can capture those metrics and we'll see how that goes.
That's fantastic. I have one last comment in the Q&A that says, "This is so amazing. Thank you for sharing your findings." And I would like to thank you again on behalf of everyone attending today for sharing this with us. And I hope you have a wonderful rest of your day.
Thank you. Thank you so much. Bye now.
All right, everyone. It is my pleasure to pass moderating duties over to Ashley. Ashley, over to you.
Thank you so much, Donna. So hello, everyone. My name is Ashley Ryan, the current Student Wellness Coordinator at the Graduate Student Association, and I will be moderating the next 2 presentations. So for our first presentation of my moderating section are being presented by Anthony Truong and Joshua Budge, and it is called Shanty App, a deep breathing tool for students by students. And for their little bit of a bio about themselves, Anthony is a 3rd-year student in computer engineering that is working together with Eng Wellness to showcase an app that is being developed for stress relief. As a student that studied during the pandemic, he understands the stress that can be developed when being isolated in one's room or being simply burnt out. He's also had experience lifeguarding, where deep breathing is a necessary tool that is used during rescues to calm victims. Today he will be showcasing the Shanty app because deep breathing is an essential skill that can be applied in a variety of scenarios. Josh is a 3rd-year life sciences student majoring in psychology. He is currently completing his 3rd co-op term with the engineering wellness team, and as part of his role in the co-op, he assists with the research and planning around the Shanty app. Josh has a strong passion about mental health and hopes to become a clinical psychologist. All right, Anthony and Josh, I will send it off to you.
Well, thanks for that introduction and welcome everyone to our presentation about the Shanty Deep Breathing Mental Health app. Sorry, just let me get to switch slides here. So we'll be going over why we need the app, what the app does and why it works, and how the app works with some supporting visuals. So overall, the mental health and overall health of students is pretty good. From a 2019 survey at the University of Waterloo with over 2,000 respondents, over 43% of students reported very good or excellent overall health, and just under 80% of students reported good, very good, or excellent overall health. However, there are many difficult periods for students. So around 90% of students at one point in the last 12 months of reporting on the survey felt overwhelmed by all they had to do, felt mentally exhausted. Just under 50% felt so depressed it was difficult to function, and over 60% felt overwhelming anxiety. And stress seems to be the biggest factor. So the majority of students reported either above average or tremendous levels of overall stress in the last 12 months. So we wanted to create a solution for these difficulties, and that's where we got some of the idea for our app. So a little bit about our app. Our app is a free deep breathing mobile phone app made for Waterloo students. It helps with some of the mental health difficulties that students face. We have named it Shanti. Shanti is a Sanskrit word for peace. It's a way to signify calm and stress reduction without the westernized cultural norms. It increases accessibility and displays openness to multiculturalism. To further clarify what was mentioned before, our app's purpose is to provide temporary relief for the mental health difficulties students may be facing. The main intervention technique used in the app is something called deep breathing or diaphragmatic breathing. So deep breathing is a breathing technique used for centuries in many world religions. It has been used extensively in yoga and meditation practices, and is just now being fully recognized by the Western scientific community as an effective solution of many mental health difficulties. The app provides an introduction to this very effective self-corrective strategy to deal with such difficulties and can eventually allow people to practice these techniques independently. Deep breathing is essentially a time-controlled breathing technique where you breathe in as deeply as possible for a specific time, breathe out for a specific time, and wait to breathe in for another specific amount of time. And you can repeat this process for given periods of time, however long you want. So the specific mental health difficulties that this app targets varies, though it is most well known for its effect on short-term stress reduction. But deep breathing has also been shown to lower cortisol levels, which is a stress hormone, decrease depressive symptoms, reduce anxiety, and improve mood regulation. The app also provides Waterloo resources for those who may want to seek help on top of these breathing techniques. So our app can also be very effective at improving mental health from social factors. The first factor that it helps in is accessibility. So in our context, accessibility means the ability of students to get access to the help they desire and or need. Our app increases accessibility because, one, apps are frequently used by the student population, and therefore it's easy and desirable for students to use another phone app like they're used to using. A second reason is that the three main groups that tend to differ in accessibility to mental health resources are differing levels of income, differing socioeconomic statuses, and race. And our app overcomes these barriers. For one, it's a free app, so there's no income associated there. There's no geographical location. It's just you download it on your phone wherever you want to. And that typically separates people on socioeconomic status because different socioeconomic status people live in different geographical regions. And there's also no human prejudice influences because it's just you and yourself using the app. So a second social factor our app improves is mental health stigmas. Although Western culture is improving in this, there's still social stigmas surrounding mental health, which may lead to avoidance of help-seeking behaviors. So students often avoid mental health resources and services due to the social stigma, but a phone app has a high amount of privacy, which would greatly reduce the effect that social stigmas have on avoiding mental health help. Our app is also one of a kind here at Waterloo. There are no other student-made, student-focused deep breathing apps. There's nothing the same as our app. It's the first of its kind. It was also created for Waterloo students by Waterloo students. So the fact that other students made it means it will be more welcoming and easier to raise awareness around. Students make it also means that there's a social influence on a mental health topic, which may help overcome these mental health stigma barriers that I mentioned earlier. There's also a rep to home team influence, which means it was made by Waterloo students, and other students may see that who go to Waterloo and then want to join in.
All right, thank you so much, Josh. So now we're going to be going over how does the app actually work. So moving forward, when the user launches the app for the very first time, they'll be greeted with a tutorial screen, as seen by the right. And the tutorial screen will cover welcoming the user, tells the user how to use the app, and reminds the user that, of course, it is not a substitute for medical help. Next, we'll be talking about user interaction. So we'll be talking about the home screen first, and on the right, you can see that the app is composed of 3 main functions, which is panic, stress, and focus, as indicated in the red, green, and yellow. And we'll also have additional help from resources and information, all of which we'll be addressing next. The panic function is used when the user is having a panic attack or anxiety attack. This is because the user will be disoriented, their breathing will be staggered, and will be in need of immediate care. On the right, there will be a circle animation in which the user can follow. The circle will fade in and out and will guide the user on how to breathe. Also, in the bottom, if you can see, there are inhale and exhale times that will tell the user how long each breath will take and last. The purpose of the panic function is because in a panic state, the user can use this to return to a relaxed or calm state where they can seek further help if necessary. Moving forward, the stress function is created to help a user relieve stress. So they might not necessarily feel like they're panicking, but at the same time, there is stress that is built up. Using this function will help de-stress a user so they can avoid the panic state. For example, for a student, it could be juggling multiple assignments or with approaching deadlines or simply exams. As shown by the screenshots on the right, the student can input their stress level using the slider. The slider starts off yellow, which is usually a color to denote happy or calm, and then turns red, which is a color used to denote anger or stress. After inputting their stress level, the user will receive a breathing regimen, followed by the same animation from the panic screen. Next, we'll be talking about the focus function. The primary purpose of this is to help students get into a focused state for doing, for example, homework. As seen by the snapshot, there are 3 preset breathing routines which a user can follow, or they can select option 4, where they can create their own breathing regimen. After selecting one of these, they'll be shown the same breathing animation as before. Now, moving on, we have the resource screen, which contains additional resources that can help the student. As mentioned previously, the app is not meant to act as a substitute for medical help, and if a student needs it, they should seek a professional. Some resources that are currently listed here are helplines, police, and university resources, and there will be more that will be added later. Lastly, I'll be discussing about the information tab, and this will cover the mission statement regarding the app as well as for our team. Furthermore, it will discuss more in depth regarding the 3 primary functions and their uses. So the short-term goal for this app is to help students gain a better understanding of deep breathing and use the app when they're dealing with stress. But our long-term goal is to have students actually adapt to deep breathing and be able to utilize it without the app. I would like to give a special thanks to Unge Wellness, Ideas Clinic Corp students, and as well as Dr. Betty. Does anybody have any questions, comments, or concerns?
Hi everyone, so if you have any questions for our awesome speakers, please feel free to use the Q&A function and I will relay that information. That's an awesome app that you're both are talking about. Now the Shanti app, is it live? Like how long has it been live for, if so? Like are students able to download it right now?
So the thing is, the app is still in development right now. It was actually a project that was created during the winter co-op term last year by the Ideas Clinic students at the University of Waterloo. So they started on the app, and I've been working on it this term, and it's near completion right now, but it's not necessarily, as you would say, live. Live would mean that would be available on like the Play Store or App Store, depending on Android or Apple phone that you have. But since it's still in development right now, it's only available to if you have like the source code for it. Mm-hmm.
Okay, cool. So is there like I know it's hard to kind of like estimate, but is there any like estimate of when students would be able to download this app in the future?
Yeah, so as I'm working on it this term, as for my work term, I'm hoping to complete this app like a complete prototype by the end of this term. And as for like any students that get this project for like their work term, I hope that they can release it onto like an app store, so it'll be live and available for other students. So hopefully, maybe within the next 4 months.
Awesome. I'm sure that will be super useful for students. And being such like a large community at UW, and maybe even students will see students using it from UW and think, hey, maybe I should download this app, even though it's UW specific. It might be even useful for students not even at UW.
Definitely, for sure. It has its uses for sure. And as as you mentioned in my presenter bio, I am a lifeguard that has a previous experience in lifeguarding. So deep breathing was heavily utilized to help victims calm down during difficult situations. For example, if they were just taken out of the water from almost drowning, for example. And definitely has like many more uses outside than just lifeguarding, as mentioned in our presentation.
Yeah, for sure. So again, if anyone has any questions, feel free to put them in the Q&A. Great. Oh, we have one. Oh, it's a comment. And it says, as a student, I would totally download this app. This is great. Thank you.
Yeah, for sure. It's still a work in progress right now. So it may seem a little bit like bare bones per se, but if the user interface is still being developed.
Okay, and then we also have a question that says, can you please say the course code again so we can find the course? Thanks. Oh, I think that might be, oh, sorry. How does the app differ from the Calm app or Headspace?
I'm not too familiar with the Calm app or Headspace.
I can mention that.
Okay, sure.
Yeah, so I believe the Headspace app is more of a meditation app. It's a mindfulness-focused app. Mindfulness is highly related to deep breathing. I think a lot of deep breathing is you breathe deep and then you change your focus out from whatever anxieties or stresses you might be having, whatever thoughts and concerns in your head, to just being present and being mindful of those thoughts. That's more so what the Headspace apps are focused on. Big thing that this app is different in is it's more so just mainly deep breathing. So it's just a quick take you through a breathing regimen, not necessarily a mindfulness, though you can integrate that additionally if you wanted, but deep breathing is a little different than mindfulness, and that's what those apps are focused on.
I also wanted to add on, I don't think those apps are specifically targeted for like University of Waterloo students. So our app targets this like the Waterloo students like population. So it would also have resources where it can help the students, such as counseling services.
Great, thank you. We do have one more question. I'm just asking for some clarification. The question is, can you please say the course code again so we can find the course? But I think that might be referring to the previous presentation.
I don't know of any courses.
Yeah, okay, it might be, I think it's referring to the previous presentation. Okay, I think we'll wrap that then. Thank you so much for presenting.
Thank you so much for having us.
Okay, so we will move on to our next presentation then. So our next presentation is by Pedro Velomonsky, and it's called Predicting the Prevalence of Stress with Smartphones and Artificial Intelligence. And the bio for Pedro is a PhD candidate in public health and health systems at the University of Waterloo. He is a mobile app developer with experiences with Android and iOS. He has a bachelor's degree in industrial engineering and a master's degree in software engineering from Pontificia Universidad Católica Rio de Janeiro. He is interested in using wearable technology to create mHealth applications that can make people's lives easier, safer, and better. Okay, I'm handing it off to you, Pedro.
Awesome, thank you very much. Can you, let me just share my screen here. Awesome, so can you see my full screen? Okay, I'm gonna take that as a yes. Yeah, good afternoon, everyone. I am Pedro Velomonsky. I'm not sure why my name was wrong there, but a lot of consonants, so I get it. And I'm gonna present today basically my PhD thesis project, which is called Predicting the Prevalence of Stress with Smartphones and Artificial Intelligence. One of the things I'm going to say is that this project has a lot of like computer science based topics, so I'm not going to go into detail on those, but if somebody wants to know more details, please feel free to let me know and I'll be happy to clarify anything after the presentation. To begin with, public health surveillance is the collection, analysis, and dissemination of data to improve population health. And one of the main sources of data are surveys, such as questionnaires and interviews, which have several limitations related to self-report, such as recall and social biases, delays between collection and reporting, and costs and logistics. An alternative to this is the use of mobile, wearable, and Internet of Things or IoT technologies, such as smartphones and smartwatches, as additional survey and assessment tools. Smart technologies have sensors that provide real-time and zero-effort monitoring of vital signs, environmental variables, and behavioral metrics, such as heart rate, temperature, movements in the house, among others. Sensor data are also continuously measured, which provides richer and more representative information. Currently, to reduce the spread of COVID-19, individuals have also been asked to self-isolate, which makes clinic measurements and in-person interviews more difficult. And social distancing for large periods of time can have adverse effects in the mental and physical health of populations. So connected devices that can safely monitor the health of individuals can be of great help during the pandemic and highlight the pressing need of using personal devices for public health surveillance and mental health monitoring. So in particular, Apple Health is one of the most popular sources of health data from sensors. Those attending that have an iPhone, they probably are familiar with the Health app, which the interface is shown here on the right side. And basically, this app collects information from smart devices that can be connected to Apple operating systems. Sensors manufactured by Apple, as well as from different manufacturers, can integrate with Apple Health and read and write data to and from it. In this manner, a diverse ecosystem of sensors can be integrated with Apple's health data repository, and researchers can then access this data with permission from users. Categories of data that are collected by Apple Health include activity, nutrition, body measurement, sleep, heart and vitals, among others. So as an example of the benefits of connected devices to public health agencies, we can consider the Canadian Health Measure Survey, or CHMS, which is comprised of an hour-long interview in the respondent's home, a visit to a clinic to collect physical measures, and use of a fitness tracker for a week. Most of the measures in this survey, such as heart rate, body composition, can be collected using smart technologies, reducing biases. Incorporating smart technologies in survey design will also minimize time and financial burdens of clinicians and interviewers, while data can be reported in real time. By leveraging the data already collected from personal devices for long periods of time, studies could also minimize follow-up losses by providing automated data collection while ensuring the data are more representative than those obtained from the weekly fitness tracker. So going into mental health, one of the variables typically collected through traditional self-report surveys and questionnaires is stress. The gold standard for stress collection in real life are self-report questionnaires, which basically ask questions like how the user is feeling, if they perceive themselves being stressed out or out of control. In addition, to collect data as close as possible to the experiences of respondents, the use of ecological momentary assessments are recommended, which involves collecting several data points throughout the day. However, one challenge is that traditionally used questionnaires in the literature have not been validated for ecological momentary assessments, meaning for short periods of time. In addition, these questionnaires can be quite long, having dozens of questions, which can cause respondent fatigue and doesn't really lend themselves to filling the same questionnaire several times throughout the day. So examples of some smaller questionnaires are the stress subscale of the depression, anxiety, and stress scale, and the Taylor 5-item measure, which are shown in this slide. So the stress subscale of the DAS-21 is comprised of 7 items scored on a scale from 0 to 3. And the Taylor 5-item measure basically asks users to select how they are feeling on a scale from 1 to 5. While lacking robust validation in the literature for the Taylor 5-item measures, several studies found that it correlates moderately with perceived stress questionnaires in the literature. For the proposed study that I'm going to describe later, we'll use both the DAS-21 and the Taylor 5-item measure to collect self-report stress data, asking users to complete a questionnaire with the 7 questions from one and the 1 question from the other several times throughout the day. In addition, Apple Health and associated sensors can collect data that are associated with stress on a physiological and behavioral level, like heart rate variability, steps, blood pressure, and sleep. Once stress data is gathered, we can then build models for stress prediction. So, for example, this table shows summaries of studies that use sensor data to predict stress using machine learning, and the several types of devices used and the variables that they use for creating the models. Laboratory studies, they typically use the known context of laboratory stressors applied while users are performing lab experiments, while real-life studies typically use a self-report stress measure throughout the day, so the user can self-report their own levels. The state-of-the-art for stress prediction model is around 70% accuracy, varying slightly depending on several factors, such as if the study is conducted in the lab or in real life, and how much what is the window of time for the prediction. So if you're predicting stress for the next minute, the accuracy is slightly less than you're predicting for the next 20 minutes. In addition, as can be seen by the works in the table, widely used algorithms are random forests, RFs, and support vector machines, or SVMs. Again, I won't really go into detail about how these algorithms work, but anyone with an interest, just please let me know. The important thing here is that since these methods have good results, I'll be using them in the study later on. So given all this background on mobile technologies, stress, surveys, it is clear that smart technologies can minimize limitations in traditional data collection methods, but they're not currently being used in this context. So there is a gap in the field of mental health monitoring and public health surveillance, as researchers are not able to access large volumes of personal, diverse, and near real-time data to better understand population mental health. So the overall goal of my work is to understand how these devices can support public health agencies through the creation of a mobile health platform, or MHP, that will collect and store health data from devices connected to Apple Health. And to validate the efficacy of the platform, we'll conduct a pilot study to collect stress-related variables with the platform and perceive stress with the self-report questionnaires also implemented in a mobile device. And this data will then be used to train machine learning models to predict stress levels of each individual. Stress was chosen as it's a major issue, with 1 out of 5 Canadian citizens experiencing high levels of stress daily, even before the COVID-19 pandemic. Plus, we're all students here, so I can imagine that you're familiar with stress levels. But this is stress is usually collected in research to self-report, despite associations between stress and the aforementioned variables. So this makes an ideal use case to see if the platform is actually helpful. So the main research question is, can smart technology data from Apple Health efficiently collected and analyzed improve survey design and support public health surveillance? And to achieve these aims, I developed an iOS app that connects to Apple Health and extracts available health data with permission from the user. The objectives of the app are to investigate the feasibility of developing this application, understand how the data extraction works, and understand the data types that can be extracted. So this is the example of the app, or at least the current version of it. So it's developed for the iOS operating system so far, extracting data from Apple Health. It was developed using Xcode, which is Apple's native program for creating apps, and the programming language Swift. So the figure shows a prototype that collects those basic data types of weight, steps, workout, heart rate, blood pressure, sleep, heart rate variability, and ECG, and also the questionnaires that are implemented inside the platform to collect self-report data. With this data, we'll use machine learning algorithms to create the models, classifying between stressed and non-stressed conditions. We'll basically use the self-reported levels of stress to train the model with the physiological variables. This in turn will be helpful for public health agencies to determine the prevalence of stress, both at an individual and at a population level. So the main variables that will be collected to predict stress include steps with the Apple Watch and the iPhone, sleep behavior with the Apple Watch and the Within Sleep tracking mat, heart rate vitals with the Apple Watch and the Participatory for wristband, and blood pressure with the Within Blood Pressure Monitor Connect. For heart rate data, we'll make use of both the Apple Watch Series 4 and the Participatory 4. The reason for using both devices is that in the Apple Watch, heart rate variability, or HRV, which is a widely used metric for stress prediction, is measured as the standard deviation of beat-to-beat measurements, which is a metric known as SDNN. This, however, is not the only feature that can be derived from heart rate variability. For example, the root mean square of differences between two heartbeat peaks is a feature that is the most widely used in literature for measuring stress with physiological signals. So the Apple Watch doesn't support that. In addition, Apple Watch only collects data based on user activity, so it's not possible right now to force a heart rate variability reading, except through the Breathe app, which those who have Apple Watch may be familiar. It's a mindfulness Apple Watch app that asks users to breathe for several minutes. So because of this, in addition to the Apple Watch, you'll use the Empirica A4, which is a medical grade device that doesn't integrate with Apple Health yet, but it has been successfully used in studies. So we'll get that data to complement Apple Watch data if necessary. We're also going to use ECG data, which has been recently introduced in newer Apple Watches, and basically collects 30 seconds of data that are similar to a one-lead ECG when the user places his finger on the digital crown of the device. This data can be used to detect RR intervals, calculate additional heart rate variability features, and so it can be used to predict stress. And to the best of our knowledge, this will be one of the first studies using Apple Watch ECG data, and to use Apple Watch in general to try to predict stress levels of individuals. This slide just shows an example graph of how an ECG data looks like. Sleep data will be collected primarily with the Apple Watch, but we'll also use the Wellbeing's sleep tracking mat, which is a mat that you put below the bed and monitors sleep duration, the quality of sleep, and some additional variables. Blood pressure will be measured with the Wellbeing's Blood Pressure Monitor Connect, which is basically a wireless blood pressure cuff. Steps will be measured using the Apple Watch alone. For the protocol of the study, we'll basically ask users to use the devices and self-report stress levels 6 times throughout the day in 3-hour intervals. Then we'll be able to associate the self-reported stress with the sensor readings on these chunks. Participants must be over 18 years old without any previous health conditions and not taking any kind of medication, and the study will last for 2 weeks. So one possible limitation of the study may occur during the prediction of stress in real life. As mentioned, we are limited by the variables that are supported by Apple Health, and we are also not sure how powerful the ECG data will be for predicting stress, since there is not a lot of evidence in the literature. So to mitigate these uncertainties, we'll complement our analysis with the Empirica. But while we plan to achieve an accuracy of around 70%, which is the state of the art, the goal of the study is not so much to develop the most advanced algorithm ever, but to show that this platform is an effective way of collecting data and achieving predictions. So a model that's based on data coming from consumer-grade wearable devices that is fairly accurate, even though it doesn't achieve 70% accuracy, will be acceptable. In addition, like I mentioned, the only way to trigger HRV reading is to ask users to use the Breathe app, in which they have to breathe for several minutes. This can potentially introduce biases in the data, since participants will relax. It's a mindfulness application. So to mitigate this, we will only collect heart rate variability data with this app only after the rest of the data has been gathered. The expected outcomes are the creation of a mobile platform that collects health data from personal devices to support public health, and the results of the pilot study to predict stress using these sensors. Public health agencies can then use these results to predict the prevalence of stress in the population and to apply personalized interventions for individuals based on their predicted stress using data collected from personal off-the-shelf connected devices. By leveraging the data that's already collected from widely adopted personal devices for long periods, researchers can collect more accurate and representative mental health information in which to study the conditions and apply interventions. To conclude, this study has the goal of investigating the use of mobile technologies for public health surveillance through the creation of a mobile platform that extracts data from Apple Health. This platform will be tested in the field starting the next month, and the collected data will be used in building stress prediction models. Ultimately, we hope that this platform will provide public health agencies with additional tools to monitor individuals securely, accurately, and effortlessly, aiding in their mission of improving population health and applying interventions to solve mental health challenges. So thank you, and yeah, please let me know if you have any questions.
Thank you so much, Pedro. For those that have just joined, if you want to ask any questions or say any comments, you can use the Q&A feature. I found this research super interesting. I know you kind of mentioned this a bit already, but in case you'd like to add, like what personally, inspired you to go into this side of engineering or to do this kind of research?
Yeah, so, well, I kind of joined health a little bit backwards. I actually have a background in computer science. And once I started learning about computer science, I just started thinking about what I could, how to develop the solution to have an impact. And by then, I just thought that health was a natural extension of that. About mental health itself was really something that just trying to think about where we can have the most impact. And also where, I guess, where there's the biggest gap, because mental health is typically collected through self-report data, whether it's stress or some other kind of variable. It's usually just collected through self-report. So we thought that if we could show that, this data that from devices that we all have, everybody, not everybody, but a lot of people today have, a smartwatch. 99% of the people, I would say probably everybody attending has a smartphone, which collects some data. So if you can show that, oh, this data that is objective and it's just sitting there on your phone can also help us to assess mental health levels and maybe improve those levels of the population, then that would be a powerful way to have an impact with this platform.
Yeah, those are some really great points. And of course, we're having this conference, wellness and mental health is such it should have always been a relevant thing, but it's super relevant now and highly important to be doing this kind of work.
Yeah.
I'll give it a little bit more time for anyone if they're still typing their questions. If no more come in over the next little bit of time, as a heads up, what's happening next is it's going to be a break. So after we wrap up here, feel free to go get some water, move around, maybe take a mini 10-minute nap, whatever you have to do for your own wellness. And we will be coming back for 2:40 for our next round of presentations. And I think that's all of the questions. So yes, thank you so much, Pedro, and see you all back at 2:40 for our next moderator and presentations.
Yeah, thank you.
Hello, everyone. Welcome back to the last part of our conference here. So there's been such wonderful information this afternoon. It's been really exciting to hear all of this. My name is Jennifer McCorston, and I'm just going to be moderating the next couple of sessions. So I'm going to start by introducing Osama Zatoun. And Osama is going to be presenting on the impact of COVID-19 pandemic on medical students' mental health and sleep quality in Jordan, a nationwide cross-sectional study. So just a little bit about Osama. So he is a recent medical graduate interested in public health and mental health research, and he's currently pursuing a thesis-based master's degree in public health sciences under the supervision of Dr. John Milkey and Dr. Philip Bigelow here at the University of Waterloo. And he has 2 first author publications in peer-reviewed research journals, and he's also participated in multiple other research projects, some of which are pending publication. So he's very intrigued to contribute to solutions and interventions tailored to vulnerable and exposed populations. So I'm going to hand it over to you, Osama. Looks like we might just be taking a moment to switch slides and screens. There we go.
Yeah, hello, good afternoon. Thank you, Jennifer, for the introduction. Not sure if the slides are visible right now. Okay, I believe the slides are being shared. Please If anyone can correct me if it's not going on. So good afternoon, everyone. My name is Osama Zitoun, and I'll be presenting today about the impact of the COVID-19 pandemic on medical students' mental health and sleep quality in Jordan, which is a country in the Middle East. So, to begin with a brief introduction towards our topic today. So the COVID-19 pandemic, without any further classifications, are known to be affecting mental health. Medical students are known to be also a population that experience a huge amount of academic and non-academic stressors, such as the nature of their compressed studies, sleep disturbances, and continuous exposure to patients in distress. Hence, there might be a population that can be affected by the pandemic consequences. Our research aim was to assess the level of fear of the COVID-19 pandemic and prevalence of anxiety and depressive symptoms, and the sleep quality among medical students amid the second wave of the COVID-19 pandemic. I'm not sure if the graph is clear, but our data collection period was done in late April 2021. At that time, the country of Jordan was experiencing the peak of the second wave of the COVID-19 pandemic. So peaking that time also give us scope to further compare our findings with findings of other studies that were done early in the pandemic to somehow take a look about how the pandemic have affected mental health. The methods of the study was a cross-sectional design, survey-based. It was an online survey based following convenient sampling, and we've sampled around 2,100 students, around 20% of all eligible students to participate, which were estimated at 10,000 from all 6 schools of medicine within the nation. The 3 scales that we have used to assess anxiety and depression, the first was a patient health questionnaire, which was a 4-item questionnaire assessing depression and anxiety symptoms. Fear of COVID-19 was assessed using a novel, newly validated scale, which was 7-item scale named Fear of Coronavirus 19 scale. And sleep quality was assessed using a single-item sleep quality scale, which is also a newly validated scale to assess sleep quality. Here's some data from the results of our study. We can see here a demographics label introducing some information about the mean age, gender, and students participating from all levels. We've also assessed the history of mental illness and family history of mental illness to make sure that it may not have an effect on the students' prevalence of depression and anxiety. Also, we can also note here that the sleep quality, as it's being compared in the blue rectangle, as it's been compared with the patient health questionnaire, turned out to be a very low mean of BHQ for total score, which, as we mentioned, assessed depression and anxiety. So excellent sleep quality was associated with good psychological status as compared with other forms of sleep as good, fair, and poor, which had a higher means on the BH4Q total score. Psychological distress was evident within the participants, with the majority showing psychological distress. When we have subscaled the questionnaire of BHQ4 into 2 main features, anxiety and depression, we have seen that around 70% were screening positive for anxiety and depression. To compare that with other studies from early in the pandemic, it was around the similar early in the pandemic in Jordan, 75%. And we cannot trace back that solely to the pandemic, because we find that even previous studies before the pandemic in 2017 have reported again 55.7% of depressive symptoms. All of these rates are higher compared to the other countries and even compared with the characteristics of the scale. Mean of the fear of the coronavirus 19 scale was 14.6, which is also indicating high level of fear, because it's around higher than the midpoint, which is 14, according to the scale characteristics. However, when we compare that rate to studies done earlier in the pandemic around the world from April to May 2020, we find a very high level of fear around that period at the beginning of the pandemic. Some examples are mentioned here from Vietnam, Spain, UAE, and Russia, all showing high levels of fear of COVID-19 pandemic, which is also, again, when compared to our level, somehow it's still high, but not very, but lower than the previous levels of the pandemic. In conclusion, medical students reported high rates of psychological distress amid the second wave of the COVID-19 pandemic, while rates of fear are still considered high, as we mentioned, above the average, above the midpoint of the scale. They are remarkably lower than that reported in early studies early in the pandemic. Recommended, of course, providing resources and access to professional help, professional mental support to students reporting poor sleep quality or symptoms of anxiety and depression. Thank you for listening, and I'm open for any questions. I hope I've not exceeded the time limit.
No, not at all. Thank you, Osama. Thank you, Osama. Very interesting. So I'll just check the chat there and see if there's any questions that have popped up. I'm hearing an echo. My question, I guess, while we're waiting to see if any other questions come in, is 42% had severe psychological distress, which seems very high. And so, do you know what supports are available to medical students? Like, is there more supports available to medical students than, say, the general population, given the nature of their work? Or are you aware of any support specific to medical students and physicians, maybe in general?
Up to my knowledge and up to our research in the area of Jordan, country of Jordan, which is in the Middle East, no, that's not applicable, because it's not considered as a high level or high risky population as compared to other university students. And we even cannot draw the conclusion that it's solely high among medical students because we do not have a comparable or some good sample from other university students to stand by our strong conclusions that it's only high among medical students. But specifically to your question, there is no specific mental health support system for physicians and medical students that I know of.
Thank you. Yeah, I would encourage if anyone is aware in the chat, if they want to add, if they know in Canada whether we have any specific, because I guess the reason I was asking it too is I know in Canada the past several years we've focused a lot of mental health supports on first responders, so our police, our EMS, but you know, something as you were presenting, it didn't make me think, or I guess I wasn't aware of what supports are offered necessarily to physicians who do see you know, have, as you said, very disrupted sleep patterns, and they deal with a lot. So if anyone knows, it would be really interesting to put in the chat of any additional campaigns or initiatives that are geared towards medical students or physicians. Okay, I don't see any other questions. I guess just like another question too is, you know, if you were to look at medical students, if you were to do a follow-up study, is there things that you'd also want to explore with this population that you didn't necessarily get? So kind of like a phase 2 of your study, if you were to do a follow-up with this group, maybe post-pandemic, would there be anything you'd want to look at or dive more deeply into?
Yeah, sure. If there's the option to go to a follow-up study, as you mentioned, the main idea would be to look for the after pandemic levels and compare that comparably with the current levels to see or to perceive to some extent, the actual impact of the pandemic without any other confounders or any other parameters that are influencing the relationship. Other than that, it would be very beneficial to add other students, other university students, samples from all applicable colleges to get some representative sample and to get some idea to draw a conclusion that is somehow strong enough when compared to other students, especially regarding the mental health and psychological distress.
Yeah, I was thinking about when you started your presentation too, at someone like you, Waterloo. We have also very high pressured programs here when it comes to being a STEM school and having, some very, with our co-ops and things. So I think it would be interesting to compare medicals. We don't have a medical school here, but it'd be nice to be comparing to other student populations and programs. Great. Okay, so I don't see any additional questions. So thank you, Osama, for that very interesting presentation, and we'll move on to our next presenter. So I have the pleasure of introducing Abu Abdullah, and they're going to present on understanding the differential impact of vegetation measures on modeling the association between vegetation and psychotic and non-psychotic disorders in Toronto. And so Abu completed his MSc in Public Health and Health Systems from the University of Waterloo and has been working in the healthcare sector, both in Canada and Bangladesh, for nearly 5 years. And Abu's research focuses on analyzing the relationship between the built environment and various health outcomes like mental health. And so Abu has published 11 peer-reviewed articles, 5 where they're the lead author, and is also a reviewer of 10 prominent international journals such as Nature Scientific Reports, Neglected Tropical Disease, Remote Sensing, BMC Tropical Medicine and Health, and others. So please give a warm welcome to Abu Abdullah.
Thank you very much. Can you see my screen? Hello?
We can see your screen.
Okay. Thank you, everyone. So without further delay, I would like to start my presentation. So I'm going to present on a research that I have conducted as a part of my master's thesis, and it tries to understand like how different forms of vegetation measures can affect the modeling of the association between vegetation and mental health disorders. So first of all, what we need to understand is like why we needed to conduct this research. So based on the United Nations, by 2050, that is like in about 30 years time, about 70% of the global population are going to live in urban areas. So for that, we need to understand how the built environments are affecting our mental health and our mental well-being. So the problem lies is that the different sort of studies are actually failing to come to a conclusion as to whether the built environment factors are actually affecting our mental health. Amongst this, one of the burning issue is like the loss of vegetation covered areas due to urbanization. So the studies, some of the studies are saying that yes, vegetation can can help with our mental health through psychological stress relief, by building our attention restoration capacity, and by promoting social cohesion. At the same time, there are studies which are saying that no, vegetation is not associated or are weakly associated. So the findings are actually inconsistent across different study groups to come to a conclusive result. So the studies that have actually found a relationship between vegetation and mental health have also noted that if you just go to a vegetation covered area for 1 or 2 days, for example, for a camping or during the weekends, this might not yield the desired psychological health benefits. So in order to have a tangible or a sustainable psychological or mental health benefit, you need to have a consistent exposure to surrounding greenness. So what we have found out.
Sorry,
yes,
sorry to interrupt. We have slides up here, and we can advance them for you, but I apologize, we don't see your slides, so you're not controlling the slides. We just have our slides up. Do you want to try to get your slides up? Or do you want us just to advance them for you?
Okay, can I again try to share my screen?
Sure. I'll let the
Can you see them now?
Unshare. Yes.
Okay, thank you.
Sorry about that, everyone.
It's perfectly fine. Oh, sorry. So what I was saying, like, so what this past studies have shown us is that if you just go to vegetation covered areas for 1 or 2 days, it's not going to bring about a tangible health benefit. You need to be in constant presence of surrounding vegetation to have any kind of effect on your mental well-being. So what we have found out that the past studies have not addressed 2 major constraints. Number one, they have not addressed the way vegetation are being modeled into an epidemiological studies. So for example, they have not considered how there could be different forms of vegetation in an area. They have not also considered like how it is important to measure the differential exposure to different kinds of vegetation cover. So for example, if you go to an area like this, you will be considered as going to a vegetation covered area, but in reality the vegetation present there is not healthy enough to affect your mental well-being. So this was not considered by the past studies. Similarly, while modeling the relationship between vegetation and mental health at population level, these studies did not consider the spatial dependence or the way that cases affect each other. So for example, if an area has a mental health disorder outbreak, it is going to affect the mental health or mental well-being of the people living in the adjacent areas. So this kind of autocorrelation or the way the cases are dependent on one another were not considered. Similarly, the over-dispersion or the intra-area variabilities due to the different characteristics of different areas were not being considered. For this, what we did was we set our primary study objective to understand how different measures of vegetation used by the studies can affect the detection of a significant relationship between vegetation and mental health disorders. Specifically, we targeted to find out 3 things. Number one, we tried to find out how indices and area-based measures of vegetation can affect the association between vegetation and different forms of mental health disorders. Specifically, we studied the psychotic and the non-psychotic disorders. We tried to find out like whether what kind of vegetation measure could be used in epidemiological studies and also the statistical modeling constraints. Now moving on to the methodology. So if we have a brief overview of what we did, we had actually 3 major components. We had the vegetation measure, and we had the mental health disorder dataset. We tried to find out an association between these two while trying to adjust for the confounders. So for the mental health disorder datasets, we took psychotic and non-psychotic disorders from the Ontario Community Health Profiles Partnership Database, and it was from a project that was conducted by ICES. And for the vegetation measures, we took a satellite image and we calculated 3 different types of vegetation measure: enhanced vegetation index, normalized difference vegetation index, and soil adjusted vegetation index. We used machine learning algorithm to develop one area-based measure of vegetation, and we took another area-based measure of vegetation from the Open Data Portal, and we used the Ontario Marginalization Index variables to be adjusted as the confounders, and also the rate of substance use disorder from the ICES dataset. And then we modeled the association using Bayesian spatial modeling. So the study area was Toronto, the spatial unit was neighborhood, and the study period was between April 2015 and 2016. This was the period of that the mental health data set covered. And to be consistent with this mental health data set, we took the satellite image of 2016 and we took the spring and summertime images to get a constant level of vegetation measured. So the mental health data set, I've already explained this. So for the mental health data set, we took the observed counts of both sexes and 0+ age. So these counts were aggregated by sex and age for these two different types of mental health disorders and check their association with these 5 different types of vegetation measures that we have talked about before, the 3 different types of indexes and the 2 different types of area-based measures of vegetation. These mental health disorder datasets were in turn developed or totaled from the different subcategories of mental health disorders. These subcategories were actually collected from different physician claims and based on different OHIP code claims. So what we did at first was we tried to find out what kind of statistical modeling technique could be used. To do that, we first of all mapped the observed counts, and we saw that the counts are actually clustered, something that we call spatial autocorrelation that I have explained before. And we also tested that and we found out that yes, the psychotic disorders are actually moderately clustered, and the non-psychotic disorders, which are more prevalent in Toronto, are actually highly clustered. So this showed us that for this modeling of association, we need a spatial approach. And for the satellite image, we took 2016 image, the spatial resolution was 30 meter and the cloud cover was 10%. We did different kinds of corrections to refine the satellite image and improve the detection of the indices. So the indices were detected based on the philosophy that the leaves reflect different leaves reflect sunlight of different wavelengths, of different bands in the electromagnetic spectrum. So we exploited that and we used these bands to develop these 3 types of indices that I've talked about before. The major difference between these indices are, this is like a basic index, NDVI is a basic index, whereas EVI adjusts for different kinds of atmospheric and canopy background noise that are present in the urban areas, whereas the soil adjusted vegetation index or SAVI adjusts for the soil brightness. So there are pros and cons of using these different types of indices. And we developed the area-based measure using the random forest algorithm, the machine learning algorithm, and we calculated the percentage of vegetation cover in each neighborhood. We downloaded the same kind of area-based measure of vegetation, which was actually the percentage of tree cover from the Open Data Portal Toronto, so that we can compare between the indices and the area-based measures of vegetation. For the confounding variables, I have already mentioned we have to taken these from the Ontario Marginalization Index and the ICS database. We also checked for the collinearity and ensured that the variables did not have any kind of multicollinearity and were not affecting our analysis. So for the Bayesian modeling part, what we did was we model the observed counts of the different psychotic and non-psychotic disorders as a product of the expected risk and the relative risk. And then we fed into our vegetation measure and the different kinds of variables. And at last, what we did was we introduced 2 different types of random effect terms, which helped us model the different types of variabilities in the neighborhoods and in the cases. So what did we find out? What we found out was that there are considerable differences between the vegetation measures. For example, if we can see that the basic measure of vegetation, that NDVI, have spectral confusions. That means it kind of confuses vegetation with different kinds of our urban features. But this was not present in EVI and SAVI. As a matter of fact, EV was like more defined compared to NDVI. And when we went for the area-based measures of vegetation, we found out the vegetation measure that we measured from machine learning was actually superior to the count-based measures that we downloaded from open sources. And while modeling the association, this was reflected. We found out that for both psychotic and non-psychotic disorders, only this sophisticated vegetation indices showed any kind of statistical relationship. That means it showed us by this negative coefficient value that with increased vegetation, mental health status actually improves. We also saw that there is a considerable effect or considerable influence of the spatial factors, which suggests that for future studies, we need to use a spatial modeling approach. We also tested whether there is any kind of differences amongst the 5 indices. We found none. But there was the effect of significance. So like whether the magnitude of the association does not get affected by the type of vegetation measure that you use, but whether you find a significant relationship or not depends on what kind of vegetation measure you are using. So what we modeled was, what we did at the end was we modeled the relative risk, and we found out that the areas where the vegetation contents were low actually had greater risk of psychotic and non-psychotic disorders. So these are the things that I have already explained, that how vegetation can, how the vegetation measures can affect our detection of association with mental health disorders. So based on this, what we recommend is, like, for epidemiological studies, you need to use a vegetation measure that can model the different types of vegetation in the surrounding areas, and not only using area-based measures of vegetation, which fail to detect a significant association between these two things. So the limitations that we had was, like, we were not able to use the eye-level panoramic imagery of green space, and the findings are applicable at the population level. So no individual level conclusions should be derived from this. And it has not assessed the performance of an index that uses the combined strength of the enhanced vegetation index and the soil adjusted vegetation index. And last of all, it could not compare the magnitude of the association because we did not standardize the vegetation measures. But at the end of the day, what this study was able to show was that there are methodological constraints that should be taken into account while detecting vegetation in population-based measures to find a reliable findings, or like to go for a conclusive finding. Thank you very much. Any questions?
Thank you, Abu. That was fascinating. Lots of great information there. I'm going to start with a question before, if anyone else wants to put them in the chat. I guess, so the takeaway message I'm seeing is that vegetation contributes to more positive mental health, or the reverse is true, lack thereof of vegetation can contribute to negative mental health. Is there studies? Because in Canada, with our very diverse climate, we might have vegetation 6 months of the year, and then we don't. So is there studies that look at the difference between those that have hot and cold climates in different countries and have different seasons?
That's actually a very good question. So the problem currently that we have found out in this area, like trying to study whether there is a relationship between vegetation and mental health disorders, we are actually stuck in this point that we cannot determine whether it would be worthwhile to analyze whether there are seasonal differences. We are actually stuck in this area where we are trying to figure out whether actually there is a relationship between these two. So once we are able to resolve this, we will be able to move forward and find out whether there are seasonal effects. So for example, whether because of the fact that there are vegetation in spring or summertime and there are no vegetation in the winter time, whether these are having different kinds of impact on people's mental well-being. But what we have seen is that people actually have different kind of like seasonal effects on their mental well-being. So theoretically, there should be some kind of relationship between vegetation and mental health based on the differences in the seasons. But right now, we could not find any study that have studied for this. This could be an area for future research.
Great, thank you. And then another question is just because thinking about being, how do we put research into practice? And so one of the recommendations of the President's Advisory Committee on Student Mental Health was about making sure that the built environment at the University of Waterloo was conducive to mental health, and making sure that we, with our planning departments, whether it's light or vegetation or trees and other things around design for built environment to be positive to mental health. So I guess if you got yourself in front of senior leadership at the University of Waterloo, what would be some of your key recommendations for maybe campus design, or how your research could contribute to some built environment planning here at UW?
So there are two things about the UW campus that we have to take into consideration. First of all, like, there are areas where the students can actually go and relax themselves and come into contact with different kinds of vegetation. But what happens is, like, the area that the academic cluster where we have the SLC, where we have the two libraries, these are the areas where we do not have enough vegetation. So we need to think about the campus and the campus design in such a way so that even if the students are indoors, so for example, even if the students are studying at SLC during the winter time, there are different kinds of vegetation. So for example, we can think about vegetation that could survive in pots, or like inside the room, or like in household, inside the confinement of the households. We can consider putting those types of plants and vegetation inside these areas so that the students are in a constant exposure to the surrounding vegetation. So like, it is like shifting the burden from students going to the vegetation covered areas to making or designing the campus as such that the students do not have to take efforts to go to these areas, but they will be subconsciously, or like without knowing, they will be always in a constant presence of vegetation. So the design could be modified as such.
Thank you. I really like what you just said, where it's shifting the burden from the student to actually creating the environment that already exists, so they don't even recognize the impact and the benefit that it's having on them at the time. So thank you. So I don't see any more questions. Thank you so much, Abu, for that very interesting presentation on the built environment and mental health.
Thank you.
And so now we're going to move to Jerica Little. So Jerica, just to give a bit of an introduction, she received her PhD in Public Health and Health Systems from the University of Waterloo in 2021. So congratulations, Jerica, where she specialized in analysis of mental health systems for emerging adults. And she also acted as the lead research assistant that supported UW's Committee on Student Mental Health, which implemented the 36 priority recommendations between 2018 and 2021. And Jerica is now a postdoc fellow under CIHR's Health System Impact Fellowship Program, specifically working with UW and JAC.org to support youth-led public health, mental health initiatives. And I really like, Jerica has also said that she has two very cute cats. So maybe, Jerica, your cats will come across the screen at some point and we can see them. So Jerica, it doesn't look promising, does it? No cats in sight.
Well, they're, you can kind of see them peeking his head.
Oh, okay, waiting in the wings.
Yeah.
For their spotlight. Okay, so Jerica is going to present today on examining care pathways and social resources among young adults presenting to psychiatric hospitals with anxiety. So take it away, Jerica.
Thank you. So got my slides up. All right, thanks, Jennifer. So as Jennifer mentioned, I was a PhD student here at UW. So today I'm going to be presenting one of the chapters from my thesis. So if nothing else, I hope this presentation will be reassuring to any PhD students watching who feel like it will never end. I have been there, and it does, and it feels very good when you finish. So the focus today is on emerging adults who were presenting to psychiatric hospitals with anxiety. And emerging adulthood refers to the transition between adolescence and adulthood, covering the ages of about 18 to 29. And a key feature of this developmental period is a series of major life changes. So, moving away from home, going to school, situations that we're probably pretty familiar with at this conference. And even when those changes are good, it still adds a lot of stress. It's a transition. And at the same time that all of these changes are happening, this age range also coincides with the peak severity and average age of onset for a lot of different psychological disorders. So overall, a pretty vulnerable period of time for mental illness. And despite that level of high need, we see consistently low treatment rates among youth and EA. And compared to other age groups, the highest rate of treatment dropout is also among emerging adults. So that's a very specific problem. And part of that is due to systemic gaps in access. So the mental health system exists, but it's very complicated, fragmented. There are a lot of barriers towards accessing it. And this is especially true for those who have anxiety. We see lower treatment rates for anxiety, even though it is one of the two most prevalent mental disorders worldwide. Not only is it common in the general population, but it's also really present in psychiatric emergency departments. And those rates have been growing rapidly over the last 10 years, especially among youth and EA. So it's showing that not only is there a need for treatment of anxiety, but there's also a desire. People are seeking help for anxiety. And while the emergency department is the most common access point to further inpatient care, primary anxiety disorders, so that being the most prevalent concern or the #1 concern that you have, is pretty rare in the hospital population overall. It's about 4% of the inpatient sample. And while primary anxiety disorders are pretty low, anxiety is really comorbid with things like depression, which is very common in the hospital. And so it's likely that we see a lot of anxiety symptoms in the hospital and maybe comorbid diagnoses, but less so the primary diagnoses. But overall, little research has been conducted on anxiety in hospital settings, so we don't really know what the care pathways look like, the treatment resources once they're there. Same with social support, which was talked about earlier today. And we don't know how this might be differentiated for those who have a diagnosis, for those who have more severe symptoms. So establishing that is really important for developing best care practices, especially as rates grow over time. So to that end, I had a few research questions. We're really focusing on the second and third one today, which is how do anxiety disorder diagnoses and symptom severity affect care pathways into the hospital among EA? And then once there, how do treatment patterns and social resources look for the people being treated? So to answer my research questions, I used Interact assessment data. Interact is a global not-for-profit organization that has developed a suite of comprehensive assessment tools for various types of healthcare settings, as you can see along here. And it has been pretty widely adopted across Canada. So I was using the RAI Mental Health, designed for inpatient psychiatry specifically. And this assessment was mandated for use in Ontario back in 2005. So my data represents all adults admitted to inpatient units between 2005 and 2019. So it's a very comprehensive sample. But I also had a couple of participating hospitals from Newfoundland and one from Manitoba. So overall, after I restricted to the first episode of care we had recorded for each person, so one observation per person, ages 18 to 30. For those who are in the hospital for at least 3 days, we had 65,000 people. And then once we included those who had a shorter length of stay, so less than 3 days, we had 98,000 people. So you can see that the people who had a very short stay, there's quite a few of them. And that was one of our outcomes, was the short stay assessments, but we also looked at formal care. So the number of days that a person had at least 15 minutes of contact with different types of professions, as well as treatment modalities. And we also looked at some of these social relationship and interpersonal conflict measures to see what their social resources look like. And the main focal point of interest was, again, anxiety, of course. We looked at that in a couple of ways. So we had the DSM disorders, primary as well as comorbid. And the anxiety scale, it is an initial one that I had developed in my previous chapter. And we were also interested in contrasting a little bit with depression. So similarly, we had disorders as well as a scale of symptoms. So like I mentioned earlier, we don't have a lot of research conducted in the area of anxiety. And so I had to make a few educated guesses about what I might expect to see. And so for today, I'm really quite interested what you would think. So if you want to go to pollev.com/jericalittle628, I would like if you would click all of the characteristics that you think are relevant. It's an anonymous poll. You can click as many as you want. And what we're looking at right now is which of these do you think would have been associated with a shorter length of stay into psychiatric hospitals? So you can do that online. I'm going to give people 30 seconds or so to submit some answers. And then there are a few more polls after this, so once you're done, if you would just keep that up. Yeah, we'll give a little bit of time for that. Okay, I'm starting to see some answers coming in. It's pretty exciting, especially for me, since I wasn't too sure, to be honest, when I started looking into this. Okay, so we'll show what we have for this one. So actually, the only characteristic that was associated with a really short length of stay in hospital was primary anxiety disorders. So if anxiety was the primary concern for the person, they had lower odds of having a longer stay in hospital. And this is likely due to administrative designs of hospitals. They're not really meant to care for anxiety. So it's a different type of care pathway. But if that said, if you did have more severe symptoms, you had greater odds of a bit of a longer stay. That's good. Okay, so we're going to move on to the next one. So for this, just anxiety, we're not looking at depression this time, but who do you think had more treatment days with a psychologist? Again, I will give about 20 or 30 seconds for you to guess. Yeah, cool. Okay, so what we saw was that if you had an anxiety disorder, either primary or comorbid, you had more days of contact with a psychologist, and quite mysteriously, for those who didn't have an anxiety disorder diagnosis but had moderate or severe symptoms of anxiety, they're somehow getting less contact with a psychologist than those who have either no or mild symptoms of anxiety. So that was an interesting finding. And we also looked at a couple of other types of treatment modalities. We looked at psychiatrists, the type of therapy received. Generally, it didn't differ too much. Usually, if anything, it would increase with symptom severity. But this one was a bit different. Pretty interesting. I'm going to refresh to the next one. So this time, we're starting to look at a couple of the social resources. What do you think would have been associated with family and friends reporting that they felt overwhelmed? I know it's kind of a weird guessing game to be playing, but from a research perspective, I really appreciate the engagement. Okay, so what we saw was that all disorders except for comorbid depressive disorders were protective against family and friends feeling overwhelmed, protective being a statistical term. But comorbid depressive disorders were the one disorder type that seemed to increase the odds of family and friends feeling overwhelmed. So that shows that anxiety and depression don't always follow the same pattern. Even though they are highly comorbid, they do have some important differences. But also we saw that severe anxious symptoms had the greatest odds of family and friends feeling overwhelmed. Which again, maybe there's a bit of a less focus of anxious symptoms in treatment, especially within hospitals. So something that we really need to be mindful of in those settings. Okay, one more. So it's also a social resource variable. We have staff reporting frustration with their interactions with the person. And what I will say up front is that this didn't happen very often. Usually staff didn't report feeling frustrated with anyone, really. I don't want to throw our healthcare workers under the bus, they work so hard. But in the few instances where it did happen, what do you think would have been associated with them feeling more frustrated? Okay. Interesting. All right, so what we see here is that all disorder diagnoses were again protective against staff reporting frustration with the person. So if they had a diagnosis, staff didn't report frustration quite so often. And I think the interesting thing we see here is that depressive symptoms had no effect on staff reporting frustration. It was insignificant. On the other hand, anxiety, specifically severe anxiety, really increased the odds of staff reporting frustration with the person. So again, it didn't happen often, but where it did, anxiety seemed to be a particular problem for staff, perhaps again because it's not something that's typically treated in that setting. All right, enough with the polls, I am done. But thank you to everyone who participated, I appreciate it. It's nice to know that nobody else had a very clear idea of what was going to happen before the results were shown, because I didn't either. All right, so in most cases, anxiety is diagnosed before depression in the general population. And so that pattern has some potential implications for prevention because we're seeing the opposite in hospital settings. So likely treatment's not being received until depression is diagnosed. We also see that the hospital is not really treating primary anxiety concerns, and you know, maybe the hospital isn't the optimal setting for treating anxiety. It could be that it is better to treat that in the community, but as discussed many times today, there are numerous barriers towards accessing community services. So that was one of the biggest implications and discussion points in my thesis. Otherwise, once in the hospital, those who had anxiety disorders didn't receive less treatment. If anything, a diagnosis was a bit helpful to receiving treatment, and even more so with the social supports in a person's life, diagnosis tended to be fairly protective. And so one that highlights the need to measure both symptoms and diagnosis. They are not the same thing. They don't have the same patterns, and anxiety is perhaps being quite under-detected. But it also shows that maybe there's a need to have a bit more public mental health education specific to anxiety in your friend's life. So this being a student mental health conference, I thought I would just end on some resources for those who think they may need some help with anxiety. For those in UW, of course, we have campus wellness, health, and counseling services, both. We have the CMHRT, numerous group therapy and workshops for anxiety, and off-campus supports. Oh, and of course, I hyperlinked all of this before I realized that it doesn't do anyone any good because you can't click it. So I gave Grace the list of links to all these resources, which I think will be shared in the chat. So don't worry, they will be posted for you. And also some for the general population. And generally, I tried to find resources that are freely accessible, knowing that mental health can be quite costly, especially in the community. So these are generally free. And then also, because we spent a bit of time talking about social supports, for those of us who feel as though we're not really good at maybe detecting anxiety, we don't have telepathy, we can develop some skills to help us recognize and respond to distress. So Campus Wellness has a lot of different mental health training opportunities for students as well as staff and faculty. And in the general population, jack.org has some resources they presented earlier, as well as CAMH and CMHA. So that is my presentation. I can keep this slide up for a little bit in case anyone would like to access any of these resources. But otherwise, I am ready for any potential questions.
Okay, thanks, Jerica. Great information that you've put up on the slide, so thank you for that. And I know there's also been some information posted in the chat about with some of these resources and links as well. This might be beyond the scope of your research, but I know you said you had participating hospitals, like I think you said one in Manitoba, New Brunswick. Do you know, either from your study or from the research, whether admittance rate for inpatient anxiety does differ by region? Like if there are Canadian differences across Canada and why that is, or is it capacity, or is there other reasons?
Yeah. So one of the next steps that I'm working on is a regional analysis. So doing some multi-level modeling with admittance, because it does, and it would differ by region. So in an area that has a lot of different hospital resources, somewhere like GTA, where also a lot of Ontario psychologists live and practice. It looks very different there compared to rural Northern Ontario or to Winnipeg or Newfoundland. So it definitely does make a difference in terms of the exact differences, and that is like the next step of research that we're working on.
Okay, great, thank you. And thanks for that. And given your specialty is in young adults, emerging adults, and you've talked about some of the campus resources, and you know, it's nice that students have this information that they can go to and or they can seek services, and as you said, through Campus Wellness. You know, are there other things, maybe this is a big question, but you think might help for young adults in post-secondary institutions to help with anxiety, whether it's in the classroom, in other areas on campus, that could be more of a supportive environment to help reduce anxiety?
For sure. So one of the PAC SMH recommendations, one that I came up with that Christine Zaza, who presented earlier today, is like an absolute expert on, so brilliant, is universal design instruction for classrooms. And the way that a course is taught, the environment that's created in a classroom can help prevent some anxiety, or can help to alleviate anxiety or prevent it. So ensuring that your atmosphere within your classroom is very supportive, that your classes are engaging, that they don't, you know, single people out, that there are support contacts. There are various ways you can structure your classes to be more accessible to individuals who do have anxiety, like having alternatives to presentations if that is something that a person who has social anxiety don't feel like they can safely do. Within the rest of the campus, I know some of the residences engage quite a bit in this mental health training that Campus Wellness also offers to help recognize and respond to those who have anxiety around you, and what kind of resources are appropriate to offer and when. And then for students themselves, I think we heard earlier today, if you have anxiety, making that step towards asking for help can be very daunting. So there are things like Mind Beacon, which is an online CBT program that can be accessed, and Campus Wellness also has some online resources that can be gotten through as well. Great, thanks, Jerica. Thank you for that wonderful presentation.
So now we've sort of come to the end of our conference, and it's been a great day. So thank you, everyone. We've covered so many important topics, whether that was the impact of COVID on mental health, sexual violence, promotion of mental health care strategies. So I'd really like to thank all of our presenters, and I'd also like to thank all of our moderators who really helped keep everything on time and to go smoothly. And behind the scenes, I'd like to thank Megan from IST, who's been a great support and running all the back and forth between presenters. And last but not least, I cannot thank enough Grace Wong, who without this wouldn't have been possible. Tremendous amount of time and energy has gone into planning this event to ensure today was successful. So thank you so much, Grace. And I just want to thank you as participants coming out, and hopefully you've learned a lot. It's been interesting and informative, and thank you for asking your questions. And hopefully this isn't the end of the conversation, so there may be things you want to follow up if you heard some really interesting information today. So by all means, please do that. And as many of you know, this conference was part of a month-long series of events around Thrive, which focuses on bringing culture of well-being and encourages you to learn about mental health and to make sure we reduce stigma, talk about mental health, support each other as a UW community. And the three goals of Thrive, of course, are to enhance mental health literacy, build healthy habits and self-care, and foster a supportive and inclusive community. So we hope that your participation today, along with other events throughout Thrive, has been valuable to you. So now I'm going to introduce and hand it over to Chris Reed, who's our Associate Provost of Students. Chris has been involved in so many student mental health initiatives on campus, always been a champion for prioritizing student well-being. So Chris is going to share some closing remarks for us. Thanks, Chris.
Thanks very much, Jennifer. And where I'm sitting, it looks like my connection's not that great. So if anything goes really wrong, just someone holler at me. Appreciate the opportunity to be here, Jennifer, and share some closing remarks after today's amazing conference. It's certainly been an important day of discussion and dialogue about student mental health. We're living in an age of heightened stress and uncertainty right now, and that applies to our studies, our work, and our home lives as well. Throughout the pandemic, the university's not lost sight of the fact that supporting our students and their well-being is our top priority, really. We've learned so much over the past 2 years about student mental health, the barriers and challenges experienced by students, as well as our ability to support students. We're laying the groundwork for long-term changes to ensure that these learnings continue and that students' mental health is at the forefront of our institutional initiatives. As an executive sponsor of the Wellness Collaborative and a member of the President's Anti-Racism Task Force Health and Mental Health Working Group, I want to close by recognizing the important work that still lies ahead for our institution in realizing our commitments to mental health and well-being. Many members of our university community face systemic barriers to building and maintaining positive mental health. There are many inequities to receiving the necessary supports for mental health, whether it's lack of awareness, varying cultural understandings of mental health, social stigma, or inability to afford services and supports. Other determinants such as low income, higher unemployment levels, and precarious work conditions really exacerbate these inequities. And as we move forward with this work, we need to do so with a lens of health equity and social determinants of health. Today's conference is part of an ongoing conversation and commitment to student mental health and wellness. At Waterloo, we recognize the importance of research in addressing student mental health through contributions of new knowledge, which can enhance students' well-being and inform universities' policies and operating procedures. It's just terrific to see such a strong program at this conference again this year. And Jennifer did a great job of thanking those who needed to be thanked, but I'd like to add my thanks as well to Grace for the amazing work that she continues to do and support our campus community in this area, the Thrive Core Committee, and the supporting volunteers for making today's conference happen again this year. Thanks to all the researchers for their enthusiastic contributions. And thank you to our students, faculty, and staff, as well as guests from outside the university who have taken the time to attend and take part in this critical discussion again this year. I wish you all the best, and thank you again for joining today. Take care, everybody.